So, good morning, good afternoon, and good evening, everyone, as we are live now in 3 continents. So, I hand over the proceedings to Dr. Shivashankar, President-elect, Indian Orthopedic Association, to take over and moderate the session.
Good evening, everybody. Good morning, Dr. Sergio. Good afternoon, Dr. Haldar. Good evening, friends from India. Friends, we have today Dr. Subhash Halder from Halifax, England. He is making a hat trick of webinars with our OrthoTV on this one speaker, one talk series. Today, he will be sharing his vast experience of tackling complicated fractures of the humerus by his innovative retrograde nail. So I wanted Dr. Sergio to be here on the panel. The reason is Sergio likes not to damage the rotator cuff, and Dr. Rajiv, Chatterjee and Dr. Thirumalaisamy will be adding the Indian experience for this talk. We have Dr. Neeraj Bijlani and Dr. Ashok Sham from OrthoTV to coordinate the whole webinar. Friends, we all know about Dr. Haldar. He originally from Kolkata, but shifted to England in 1974. Since then, he has worked in various capacities, and at present is working as a senior consultant in Chatterjee Royal Hospital, Halifax, near Manchester. He is the innovator of the gamma nail, the Haldar retrograde humerus nail, the Haldar tibial nail, and the recently introduced Haldar's Halifax nail for the intertrochanteric fractures. Friends, gamma nail has been sold all over the world. He is the person who invented this. When 1 million gamma nails were sold by the Stryker Medica company, they presented Dr. Haldar with a golden gamma nail. This is his achievement. He is very much associated with India. I have been seeing him since late 90s in various IOCons, but the first time I had the opportunity to interact with him was during the IOCon 2006 at Delhi, where he was part of the nail subspecialty meet. Recently, he was in the Kolkata IOCon also. In between, we have met on so many occasions like NailsCon, operative nailing course, and so many other things. He has even come to Sholapur. The reason why I'm showing is all the people who are on the panel except Thirumalaisamy has come to Sholapur. So I'm showing the picture of everybody in Sholapur. This is Dr. Haldar's retrograde humerus nail. And our first panelist is Dr. Sergio Rowinski. Sergio Rowinski is a shoulder and elbow surgeon from Sao Paulo in Brazil. He's in constant touch with Indian surgeons since 2010. And he is the one who has taken the Shoulder Planet and YouTube, and every Saturday he puts up a new tip or some video on this planet. It's a very useful YouTube channel. All of us should subscribe. So this is the name of the YouTube channel, that is the Shoulder Planet. Sergio has come many times to India. Probably he is losing count how many times he has come, because last year he had come 4 times to India. So this is in 2015 when he came to Sholapur, when I was the president of Maharashtra Orthopedic Association. Dr. Sergio came and gave one of the orations. He gave many talks on humerus, bridge plate, as well as conducted hands-on workshop, as you can see in this picture. This is Dr. Sergio after giving the oration. Friends, this is just a innovative idea to have 2 rostrum in a conference. One was having a window-based laptop and another was an Apple laptop, because different people will have different laptops. Not to have trouble, we had 2 laptops, and that saved a lot of time. Just a tip for the people who arrange conference. This is the whole group of India people. You can see so many people. Dr. Rajiv Negandhi, Dr. Adarsh Mehta, Dr. Pradeep Patil, Dr. Swapnil Kotadia, Dr. Ashok Pagarut, Dr. Bijendra Singh from UK, Dr. Sudhir Warrior, Dr. C.N. Kulkarni, Dr. Hemant Patankar, Dr. Padke, Ajit Padke, Milin Joshi, Bandari, Dr. G.S. Kulkarni. All these people are there on the India group. And we had a great photo with Dr. Sergio at Sholapur in this conference. Last year, I met him in few conferences. One of them was Karnataka Orthopedic Society's arthroscopy conference, that COSCON. Our next panelist is Dr. Rajiv Chatterjee. He's a trauma and replacement surgeon, works in Columbia Asia Hospital and CMRI Hospital at Kolkata. He has worked as faculty for various courses of trauma, arthroplasty, live surgical workshops under various platforms, including TraumaCon, NailsCon, IOCon, Operative Nailing course, and others. He has written chapters in the books, and his special interest is trauma and reconstruction of simple and complex fractures, hip, knee, primary and revision arthroplasty. He is a DNB guide also. This is Dr. Rajiv Chatterjee during one of the operative nailing course, which was conducted at Cooper Hospital in Bombay. Recently, just before the lockdown, Dr. Rajiv was here in Sholapur to attend our Solapur trauma meet, which was mainly dedicated to elbow injuries this time. The last faculty is Dr. S.G. Thirumalaisamy from Coimbatore. He is at present the sitting president of the Tamil Nadu Orthopedic Association, or the TNOA. He heads the Department of Orthopedics at KMCH, or popularly known as Kovai Medical Center at Coimbatore. Thirumalaisamy, this is an invitation for you to come down to Sholapur, because other panelists have already come at least once to Sholapur. So I request you to attend some of our conference in future. Welcome all for this today's meeting. I hand over the proceedings to Dr. Subhash Halder for talking on retrograde nailing of humeral fractures. He will be sharing his experience from lower fourth humerus fractures to split fracture of the humeral head. Welcome, Dr. Subhash Halder.
Thank you very, very much, Shivo. You're my good friend. I don't think I deserve that much of credit. I don't know how far I'm going to go. I'm just sharing my screen. Can you see my screen? Can you see my screen?
Yes, you can proceed, sir.
Yeah. Fine. So thank you very much. Thank you, panelists. Dr. Rajiv, I forgot the name. What you can tell me again? Rowinski and Dr. Chatterjee and TMS. Thank you very much. They have the much better experienced person than I am. I'm simple ordinary guy doing little job. Nothing much. I'm in the Halifax hospital. It's not a teaching hospital, but I stay here nearly 48 years continuously. They like me, and I also like the society here. So I carried on. So I will show you my little experience. What I'm trying to show, the retrograde humeral nailing, I will tell you in the beginning, it's place, limitation, and technique. I'm not comparing to any other, not I'm claiming this is better than the other. I'm simply telling how I fix the humeral fracture, as simple as that. That's not things. So please forgive me if I'm going to say that this is better than the others. It is not the case. Possibly you might agree, you might not agree. That's up to you. But the way I fix the fracture. And also I'm going to some apology to my viewers that I will not be able to show that many clinical pictures, because the atmosphere I work here at present now, it's very difficult for me to take a clinical picture in the clinic when we have got a quite restricted time-bound clinic, and I'm not allowed to my personal phone to take any kind of patient's clinical picture. It is completely forbidden now. You have to send to the central department of the hospital, and they usually take it. You have to fill up a form for that, and 50% people on the patient really doesn't attend when you discharge the patients. So that's my problem here. So I will carry on to see how I fix the fracture. The treatment of the humeral fracture, irrespective of whether the pattern is simple or complex, remain controversial. Why remain controversial? because some sections of shoulder society people say result of the conservative treatment of the humeral fracture is as good as operative treatment. But other section again they say result of the conservative treatment of the humeral fracture is not as good as we think. So you realize one section say yes, one section say no. So what are you going to do? So whatever the case may be, we are going to train how to fix the fracture. So forget about the conservative treatment. We can do the plating or nailing and the approach. Nailing integrate, retrograde approach is integrated to it. I'll be talking about this retrograde nail and modified retrograde approach. What is the integrated nailing? This is the way used to do now, possibly many places people does. This is the most important structure of the shoulder. Without this little rotator cuff, shoulder is useless. So knowingly that, how can I make a hole down there? When shoulder society people again saying 50% of people, they come to their clinic above the age of 50 with some problem of rotator cuff problem, like this kind of things. So even that kind of things, if I make a hole, they're more likely to have this problem. So that's why possibly nowadays, they are having a better nail with a much more medially, avoiding the rotator cuff. They did the osteotomy and put the much better. This is a much better position of the nail, no doubt of that. But it is a nightmare if you want to take it out, because you have to do the osteotomy again and you have to dig out quite a lot of articular surface. And you know very well how difficult to take any nail to take it out in these awkward positions. So that is one of the reasons I usually don't prefer integrated nail. Retrograde nail is very good, don't touch at all the rotator cuff, but problem is here, conventional retrograde nail, they make a hole 1 inch above the olecranon fossa. From a childhood, I wonder why should be above the olecranon, 1 inch above the olecranon fossa? Because if I took a 50 XA of the elbow with a full extension, each time I found there is a 5 millimeter gap in each olecranon, tip of the olecranon as well as the roof of the olecranon fossa. And if I take an axis of the lateral view from the center of the head and pull it down, it goes roof of the olecranon fossa. If that is the case, is not it better to make a hole on the olecranon roof and take a part of the posterior cortex so that we can make a hole like that way and then put the nail inside, like this kind of nail, which I'm describing already. Siva mentioned that there's a 3 hole in the top end. This tri-wire goes inside the nail, come out of this proximal end to the head of the humerus, and is a distal end is got a plate over the condyle held with 2 screws, and also I've got a added rotational stability with a locking screw from the proximal end. So that's the way we do the operation like that way. The hole I made it in the proximal is already covered of this plate. So there is no weakest point in the proximal end. And you can see this is that way we fit the fracture. And triangle of this is the basic of the, well, geometry, all these kind of structural geometry things. The Egyptian pyramid like that way, all the old kind of structure like that way, and also same triangle axis goes on to the modern structure as well. So it has got a basic principle of that. So I'm going to tell you some kind of fracture what I fixed from the proximal end up to the distal end. Just going to touch. It's quite a big subject. I want to try to 2-part, but Shiva and I possibly both agree it's better to do one section. So I'll carry on with touching 1 or 2 examples of each. First, I will try to explain my operative technique and mechanism exactly will be the same. It will be stereotype. If I can do operation, anybody can do the operation. Only thing a little bit different with the reduction of the fracture. So I'm fortunate enough to have a table like that with 4 foot long tall, it's completely translucent end. It takes more 70 to 80 kg weight without any support of this kind of end. And also I borrow this kind called the leg spreader from the surgical department for the varicose vein spreader, putting on the top end of the extended table. So head will be patient down there and arm will be here. Like that way, put the patients on down that way. My C arm will be the top of the head of the patients, and I can do true epi view. My arm will be exactly on the over this leg spreader, and lateral view, I get a very good lateral view on the same, leaving the without any rotation of the arm, with a true lateral view rotated the C arm underneath the table. So that's the way I don't move the shoulder at all. Having a bit of operative technique, this fracture, I put the patient like that way, and then one towel wrap up with the over the other side of the other side from the back of the patients, coming up the scapular region and fold it over the chest of this side to have a counter traction. That's the way we put it down that way, and then draping up. My mechanism of the fracture, the proximal end will be stereotype exactly the same. What is on my right hand will be this is a traction and there's a counter traction. My right hand will be up and my left hand will be down, as well as the medial displacement to rotation. That's three mechanisms, three kind of things. If you can do it very carefully, you will be finding very easy to reduction, which I usually get with that possible, as long as you get the fracture within 3-4 days time. If it goes beyond 1, 2, 3 weeks, then it's a problem. So I made a hole in the olecranon fossa, tip of the olecranon down to the about 5 centimeter top proximally, clean the soft tissue, and this is that roof of the olecranon fossa as well as the posterior part of the humerus. And I put 2 lever on the other side to the center point of the humerus, and from there 15 millimeter, 10 millimeter make a hole. I make it with a marking point on that way on this posterior part of the humerus as well as the roof of the olecranon fossa, and make a hole down that way. Once you make a hole, there's sometimes a bit of rough end. I make it smoother with some reaming process. And this is one of the most important aspects of my operation. I cut the end, very sharp end, and bend about 5 millimeter down the to the distal end and slightly bent. I'll show you why you need that thing in each and every case. So guide wire goes down to the fracture side as you made a hole down there. My guide wire is stuck in the fracture side, and I prepare the first to distal part of the humerus, everything ready. And that will be decided what kind of nail I'm going to use, it is 7 or 8. This is 7 or 8 millimeter. And I can leave that reamer up to the fracture side, or I can exchange with the exchange tube. That depends on the availability of the exchange tube, and that's it. So I leave this one as it is. Now I go to that reduction, it comes. So this is the traction goes down that way, and somebody is going to give it a counter traction on that way. Now I'm coming to the field myself. My one hand will be, right hand will be the elbow, left hand will be in the just proximal part of the distal fragment, like this place, and then simple push it down and medially, you'll get the reduction like that way. Nothing else, you get the only thing you got to be carefully reduced that way. Once you get this reduction, that's fantastic. Only the holding the reduction like that way, just need a bit of push down that way. And then you got to have this bent tip guider. My aim will be go to the medial half of the head of the humerus. That's the need I bend of the guider. And that's I'm trying to push it down with the holding the K wire and gradually seeing the first AP as well as the lateral view, center of the lateral view and medial part of the head of the humerus. That is my aim, and I try to avoid as much as you can making any false hole. So try to do repeat AP and lateral view, and that's the most important steps of the operation. Once I get that better place, then my aim will be not at the tip of the guider, my aim will be the bent part of the guider. Where my bent part goes, that's the part will be stop will be the nail is down there. So my aim is this point, not that point. So I carry on like that way. This is the better place, not just on the medial side of the head of the humerus. So after that way, I reaming the up to that level. Then after the reaming, let that bent tip guider removed from the distal end very carefully. This is a bend end. If you're not very careful, then you might look destruct or just remove the reamer as well at the same time. So that to be carefully remove the bent tip guider. Then you got to put the straight guider back again. One of the straight guider, put it back again up to the subcortical area. Then I take the measurement with the subtract positions. But another guider. This is the hole I made it. And that's the roof of the olecranon fossa. That's point I got to take the measurement. So I put another guider, second guider down there. That is the end of the first guider. That is the measurement I'm going to take it, what nail will be. And then assemble with the nail with the full flexion of the elbow. I'm gradually, just so carefully progress the nail. But nail had to be stuck every time. Doesn't matter what nail I put it on. I always stop at the fracture side to see the fracture reduction as well as the guider is the right place or not. But many times you have been saying when you put the nail in, sometimes guider retracted. So I got to see that the guider right position or not. So I'm going to see the guider right positions. Then I gradually increase my hammering up to the subcortical. It will be about 10 millimeters from the articular surface to that top of the nail. That is that basic things I always do. And then tri-wire with the help of the tri-wire goes down that way. I will show you that way. And that's the stopper, put it on that, two screws down that way. It's easily put that the stopper goes down there. And you can see the full extension of the elbow is there is no impingement of the elbow at all. This is the post-op exit. That's the basic of the operation I do like that way. So it will be quite easier for anybody if they can to follow these little tips. This is the one that kind of follow. I make a hole like that way. Again, this fracture, I ignore the fracture now. I goes after, I prepare my distal part of the humerus as much as you can. And then here I put the exchange tube, now with the traction and counter traction. And then I did exactly the same way. My right hand was in the elbow, left hand was in the like this position. Then push it down and pull it laterally and the reduction like that way. So once you have got a good reduction, then the next to the operation exactly stereotype, just put the bent tip guider in and maintaining the center of the lateral view and the medial half of the head of the humerus. And this is the position will be my nails. I'm trying to do that position nail. And the exchange tube goes down there. I pull that bent tube guider out to the exchange tube. I put the straight guider in. And then I measure the length of the nail again. This is the hole, and there's the roof of the olecranon fossa. And after the measuring the nail, I exchange tube removed, and then nail push it down. All the nail is stuffed at the fracture side, then push it in, and the tri-wire goes in, and proximal screw goes in. So that's the basics way I always do this operation. This one is that at the end of this operation we do. And this one, exactly same way I did it. Well, this is kind of result, you will get it without touching the shoulder, except you make a little hole. This is the patient is a mother of a clinician of the very high profile teaching hospital, is a physician consultant. And they treat it like that way. Was the first, this is initial issue. There's the first week, second week, third week, fourth week, fifth week, this is sixth week. Now what we're going to do? It is a troublesome period. Now 6 weeks time, that is a difficult to do any kind of replacement now because rotator cuff with the head, there's nothing down there. You can do the reverse shoulder with this kind of lady with the 60, very soft scapula will be quite don't task. So that consultant rang me and sent it to his mom to me, and I had to open up this one. I managed to put it down that way, then it's go back. And she's doing quite well. This is 8 weeks. He sent me the X-ray point. All right. So those who are very fond of conservative treatment, I think you have to be careful if you want to follow the patient very much. Sometimes I use a threaded guider for the reduction. This kind of fracture is quite rotated, a little bit of combination down there. Now this is that exactly same thing I prepare it. Now I'm trying to reduce it. Look at the distance between the scapula. Quite a bit of traction I give, but I simply cannot reduce any further than that. Still I found the head is rotated posteriorly. So I put that one of these kind of threaded guider. I put the tip of the scapula, so the tip of the acromion down that way, make one kind of small puncture hole. This is my 3 millimeter threaded guider, goes direct that directions. And slowly, you just push it back to the, going to the elbow and just also to the floor so that you can rotate it back from posterior to anterior. Then I got a good rotation down that way. Once I got a good rotation, then you put the bent tube guider in, as I said before. and then ream that with the flexible reamer up to 7 or 8 millimeter, depends on the what kind of nail you are using, either 7 or 8 millimeter. Once it's used that nail finish, I always extend that my guider in subchondral bone area to avoid any kind of destruction or displacement of the wire. Otherwise, it always come out or distracted. So I put the nail, stop down there, and the fracture site. Then put it back, try wire on screw. So that is the fixations, and that is that after 1 year, if you say it on that way. I think it's broken screw because they had a kind of dynamizations happened itself. That is this whole image. Now, sometimes I use the lever for the reduction. The 76-year-old patients is a quite a bit of combination down there all around, and subcapitical type of fracture in the funnel shape, but proximal end and distal end you can see. These 2 weeks time, exactly same way I prepare it down that way. Then a traction to traction is not happening at all with my initial technique. So I put that lever down that way to idea to take the head out. So I put that lever on the inside that way and then lift it up. Now you can see my lever starting the medial side. This is the medial side, but lever goes to the lateral side. And from the lateral side, I get quite a good of head now back. Once I got the head back, now whole thing depends on who is helping me, my assistant. If my assistant is good, careful, then I will do the good job. But sometimes you get a different kind of juniors because they need to rotate around training. Some people are very interested, some people are not that interested. So it depends on things. But most of the time, they're very good. So having that reductions, I'm quite happy with that, as long as I can keep the reduction. Then other things that's quite a stereotype for the exchange tube down that way, exchange with a straight guide wire, and then measure the nail, and then because it's a soft bone, I put it off as subchondral bone to stop kind of retracting the guide wire, hammering the nail. And then the nail goes up, stop down to the fracture site, and this 10 millimeter distance, I stopped it, and the tri-wire goes, and that's the distance of the polychron area. So this is that fracture, and that's that after 6 months fracture heals. Sorry. Sometimes I do both threaded guide wire and the lever both together. So this is the fracture. It's quite rotated now. Articular surface is quite rotated inferiorly and posteriorly. So I'm going a bit of rushing because I've got quite a few slides to show. Otherwise, possibly she will stop me. So I'm going with this. Please stop me if I'm rushing too much. Sure.
Fine. This is fine, sir. Yeah.
Carry on. Fine. Good.
Yeah.
Good. So I prepare as it is. I ignore the fracture side. Doesn't matter. I prepare the last time. I already know what kind of nail I'm going to use it. I tell the sisters, get ready for that particular nail. On a length, I've not mentioned that thing. So from there, I made a little neck. This is my bent tip lever goes down that way and goes the other side. Now lever lift it up and push it down that way. From that lever, I can manage to lift up this articular surface from inferior to superior, but rotation, I couldn't maintain that one. So I took this one out, put the threaded guide wire in, and then from threaded guide wire, I made the very good reductions like that way. So once I get the good reduction like that way, with the threaded guide wire, hold the threaded guide wire, and then other thing will be exactly the stereotype. That to put these bent tube guide wire go to the medial side, but one did I mistake here. This, my flexible reamer, possibly you can notice my flexible reamer, this is 7 millimeter flexible reamer. It is a conical shape. That's my old set of nail. Nowadays set of nail is not that conical, so I don't like that way. So I kept my old set of nail. It's helped me because I nose, tapering nose is very important. So I kept that one and I stopped that thing. It should have been not stopped. It should have been gone farther in because that is a fracture down that way. I got to go slightly more medially. That's a mistake I did it. I realized after that, but it was too late. I already put the straight guide wire in now, and that straight guide wire should have been gone further somewhere here, that way. So anyway, at least good reduction down there, and fix it up with the tri-wire and with this one locking screw. Now, this is that X-ray after, sorry, 6 months, fracture heals quite good positions. Now, fixation of the fracture proximal humerus in the teenagers group. These 12 and 16-year-olds, I don't know what that Indian disease goes. They possibly play more cricket, but in Britain, they're much better. Rather, they're very fond of football and rugby. It's very difficult to keep them at home or in the school. They're so kind of active. That's age group. They're very active. So having a treatment, this kind of fracture, with this conventional way we do the K-wire, multiple K-wire put it on, it doesn't work because possibly they don't keep the arm as rest as it possible. Then put the more K-wire down that way. It's damaging more your growth plate rather than anything else. So in that case, when this kind of fracture kind of remain, this kind of problem coming back again and again, I usually fix them off like that way. This is your growth plate. I didn't touch the growth plate. I fixed it up. This is the fracture, and I fixed it up. And that's after 1 year, fracture healed nicely. And that's that after 1 year, I removed the implant. So I have got quite a few examples of that. Since I showing that to my colleagues, now I most of the time fixed this kind of fracture, 12 to 16 with this kind of nail having a K-wire multiple. 3 to 4 point fracture. Some of the 3-point fracture doesn't need fixation of geta tuberosity, like you can see the geta tuberosity, quite a bit of fracture. This one, they treat it conservatively, 2 weeks, 4 weeks, now gone that way. Now they are thinking they will do the reverse shoulder, but patient landed in my clinic. So I thought that I will fix it up. I managed to fix it up like that way and hold it like that way, avoid any kind of shoulder injury. Exactly similar method as I showed until now. Same way I fixed it up. So some of the fracture you need sometimes fixation, but come back quite good in a position during reduction. This is quite a bit of chunky geta tuberosity is separated. Exactly same way we did. We prepare the distal part as we normally do. Then we do traction contraction. We reduce the fracture, and then we put this kind of what you call this threaded guide wire to have a better rotation problem, because still there is a bit of kind of Vargas deformity down there. So I tried to rotate it up and put it back down that. So that's got the good result. Reduction I got it. Holding that position is sometimes quite difficult. Again, that depends on who is holding my threaded guider. You can have, this is what you can see, there's a bended guider like that way. Now you can see this one is straight. Now push it back. This one is the lateral view down that way. So all the times I have to remind them hold it, please, because otherwise it's going to be displaced like that way. So majority of times, as you say, they're very good. They're helping me as much as they can, but I have to compromise sometimes. So this bended guider try to go as medial part as much as I can do. Then I put the exchange tube, which is exchange tube down there. It came out. It should have been down somewhere here. And then I put the bent tube guider back again in the center part, and that reduce the fracture again, because this is a fracture displaced. I'm going to do a little bit of pressure down that way. That's now better positions. And then I put this flexible reamer, my 7mm conical reamer, put it on AP and lateral view. And then bent tube guider out, and the straight guider goes in. And again, this is the good quality of the bone. So I have to remove a part of the head and the nail in. So why I'm saying this fracture side all the times, then now we can see what's happening down there. If I'm going to bend that that without seeing, I'm going to bend the guider. This is a 2mm guider. It can easily bend it. So these positions, I reduce the fracture back again to the further any damage to the guider, and then push it up in there. Then now this lateral view and that lateral view is quite straight and much.
Mr. Haldar, just to interrupt regarding just that point, you are repeatedly telling that you bend the guide wire. Because you bend the guide wire so that the nail which is straight, when it goes in that bent posture, automatically the head goes into valgus. Is that the reason or anything else?
No, this is not bend guide wire. This is straight guide wire.
Yes.
I
No,
changed that guide wire to straight guide wire.
No, you give the bend to the guide wire just so that the guide wire goes more medially into the head. When that is replaced by the straight nail, and it will go into valgus. To get the good valgus of the fracture, you are bending that guide wire. Is it that correct?
Yeah, that's correct. Yeah, my whole idea to get the, because head relation between the head and the shaft angle is 30 degrees. So idea is to go much more on the medial side, medial half of the head is better. And sometimes you will see unseen greater tuberosity fracture. So to avoid that bit, to get a medial half of the head rather than the lateral half.
Okay.
So this medial half of the head is moving, because this is a sometimes unseen greater tuberosity fracture may be available, may be present down there, which sometimes you don't see. So that is the better place to, you can see the distance between there and distance between there to there. So this is the medial part I try to put it on. Okay. And that lateral view will be the all the equal side, both sides. So that's, I feel that way better, because I have seen so many times that there is, when I put it on, when I have the proper check access, sometimes I can see the linear fracture goes down that way, even though it's not displaced, but there is a fracture. So after that, we fixed up the tie wire and this on the locking screw. And again, you can see that full extensions, there is no impingement at all on the olecranon, tip of the olecranon. And that's that fracture doesn't need fixation of the greater tuberosity. It holds with this locking screw, and the fracture heals reasonably well. When sometimes does need that fixation, this is that young girl over 33, I had to fix it, open up the fracture, and this fix it like that way. And that's the movement she usually gets. The movement. How do I fix the fracture? If you can stay with me for whether you like it or not, that's different things, but please stay with me how I do the thing. That is that plastic diagram. That is the typical kind of displacement of the greater tuberosity displacement. Little bit of proximal pull with this rotator cuff, and this always there's a waist of it, and the spiky end always goes laterally as well as the posteriorly. Then always get stuck in the muscles. That's fine, difficult to reduction. That's why you need to be more exposure. So what I do, having at that, I sometimes you have to use that one to reduction. When you do the hook reduction, always this go laterally as well as posteriorly. How can you avoid that to go to the posterior displacement? So what I do, I put an incision down there, put my index finger down there, try to find out the posterior edge of the fracture of the humerus. That is the posterior fracture of the humerus. And I put the 1 to 2 millimeter threaded guide wire about 2 millimeter away from the posterior edge. That's what I usually call this as a gliding wire, 1 millimeter the guide wire. I put that one. And then when you put that one, then I put an index finger inside, thumb on the over the skin down that way, in the center part of the greater tuberosity. I put another nick and then put the 2 millimeter threaded guide here, which normally you can have a DHS, and goes through the greater tuberosity only, nothing else. That's like that way. Once you have that way, that one is called the reduction wire. It means that you got to pull it down. So what you got to do, this one helping to pull it down. Once you pull it down, the spiky end will not go any further posteriorly. It will glide over there and fall back its home. So once you pull it down that way, this is the one. So I can pull it down, this one that direction, then is rotate it back that direction. Once you go that way, this spiky end will fall back on the home. So that's a simple kind of way I try to reduce it. Once you have the then this reduction wire go through and through the head. Once you have that kind of reduction, then you got the one kind of that is the 1.2 another guide wire for your leg screw at the proximally as well as one distally, and then put the screws on either side. I always keep the screw to 2 or thread outside, because this is that not 100% reduction. If you try to tighten at the moment now, it will going to have a crack soon if it is not fully in the home. So I leave 1 or 2 threaded outside. And when I put the second screw down that way, then these two simultaneously, I try to put it down. Either one screw and then there's a second screw. There's 2 and 2 either alternately, or if you got the 2 screwdriver, you can do simultaneously, avoid any crack in the middle. Sometimes you can see the unseen fracture in the middle part, the gutter tuberosity you have seen. So that's the way I usually do this kind of fracture. But when there is a kind of fragmented fracture, I usually not only use that gliding as well as the reduction wire, I use the help of the hook to pull it down that way, so that you can avoid any further displacement of the fracture. Now, have the demonstration again. This is 3-part fracture. I fix the 2-part like that way. This is the typical displacement, what I already explained with the plastic bone. There's a proximal displacement as well as outside opening like a book. How can you open up the gutter tuberosity? If I make a one line draw from the lateral epicondyle, proximally is go to the bicipital groove. There you go. Once the bicipital groove, I made an incision down there about 5 centimeter down that way. Then the longitudinal blunt dissections, I split the muscles and then put the finger inside. As I said, the finger inside, that's my finger goes in down that way. And I try to find out the posterior edge of the fracture side of the humerus. Once I put the posterior side of the humerus, I put the 1.3 millimeter, 1.2 millimeter threaded guide wire. I put it down that way. This is my 1.3 millimeter guide wire. It goes down there. Once I goes down that way, then my next job will be put this here reduction wire. This is the reduction wire, 2 millimeter threaded guide wire. My thumb is down that way, make a small little incision, threaded guide wire going down that way. Once I go down that way, that's the reduction, I put it down that way. Once I have it that way, then you pull it down and reduce that way. And that's the whole idea, to reduce the fracture. And that's done that way. You can see down that way. This is the guide wire. This is my reduction wire was laterally now gone to medially. So that's the way you can reduce this. That's the way reduction done. And I had to put another second guided wire because I found there is another kind of fracture down that's holding down that way. So that's the way I can close, completely close of this, which is open up the fracture of the gutter tuberosity to the head of the humerus. Once I have the reduction from there to there, then only things need to do the 2 guided threaded guide wire, which I put it down that way, 2 lag screw. And that's the fixations after that. So that's the way I normally, this is the insertions. So I do this gutter tuberosity fracture. Similar way, this kind of fracture, I usually fix down that way. That is that fracture. You can see this split head like that way. If this patient is 88, if you think I am a madman, sometimes my colleagues say, Mr. Halder, they raise their eyebrow. What are you going to do? He's 88-year-old man. How are you going to fix it up? I said, look, only thing I can do, I will make a hole in the elbow. That's the only thing. I will not do anything of a shoulder. Don't want 2 or 3 puncture hole. I'll make it. So this is the position I'm that way. That's the position on the lateral. We can see this plated down there. And I prepare the posterior part as much as you can. Then I use the lever to, this is that head displaced like that way. So my lever is completely out to try to push it from posterior to anterior part as much as you can. But as you remember all the time, so there's a very soft bone, so handle very carefully. I was not bringing back the whole head of the humerus, so I took another help for the threaded guide wire to put it back that way. So now they can carefully consider my threaded wire started the medial side is slowly gone back to the lateral side. Once I managed to go to the threaded guide wire to the lateral side, I can see the glimpse of head on the glenoid side. So that makes me quite happy with that, to see that way. Now, how am I assistant going to hold the threaded guide wire in a position? That's the whole thing. So once I hit that, get in their head rotated back to the own positions, then other thing is very simple. Just to the guide wire around, measure the things, and come off that way. Fixing the gutter tuberosity, as because this fracture was quite a few weeks old and it is a combination down there. I didn't open up that much, less all manipulation is a little better. So I had a prong. This is the 2-hole prong. You just small little incision, I put it down that you can rotate in different direction as well as hold the reduction. So that helped me. I'm holding the reduction with some rotation, and then I put it to K-wire to have a crosswise to lag screw. That put in the 2 lag screw that way. And that's coming out on that position after fixations. So after doing that way, these are the things, these are 6 months, you'll give me the result of that. So agitated woman, you can do whatever you like it, but I can see that you can reduce this fracture and it can reduce and fix like that way, even she is 88. So again, 44-year-old woman like that way, you got a bit of better tuberosity. Again, it is more than 4 weeks old. When I came to my place, I fixed as you like that way as a 2-part fracture. Now get a tuberosity displacement down there. What I sometimes I do, I put a small little incision down there with a finger. I try to rotate but that way, and with the blunt end of the instrument, or like a threaded guider, I put it on that way and reduce fracture that way, hold that way, and put the 2 guider rather than this too much opening of the gutter tuberosity. Less handling the gutter tuberosity, it is better, because sometimes we have seen so many best way to fix it up that way, ultimately gutter tuberosity get absorbed. So once you have that way to fix to the 2 guide wire and then 2 leg screw, put it on, and this come out on that way. Ultimately, didn't have it. Even so, after 1 year, I took the 1 screw out because there's one, 2 is what do you call this leg screw bit protruding down that. I took it out, but part of the gutter tuberosity was absorbed also, even though I didn't open up this fracture. But otherwise, she's doing fine. So 4-part fracture, sometimes it doesn't need fixation of gutter tuberosity. This is that quite comminuted fracture. Again, come to me, it was a bit of few weeks old. But as we said, stereotype operations is a distal part. You prepare the distal part, forget about the fracture side at the moment now, put the exchange tube up that way. Then your traction, contraction, you can see that I did shoulder displacement down there. Once you have got that reduction, I usually quite happy with that. Once you have got a good reduction, simple push it down that way and the elbow up, you will get the reduction line that way. As long as you with a little bit of care, not too much kind of manipulation. And you fix it up, and then the exchange tube straight guider goes in, and again I put it on further up to the subchondral bone, measure the guider for the nail, and then put the nail arms up to the subchondral lesion about 10 millimeter away distance from there. Then this is a gutter tuberosity. When I'm going to reduce the gutter tuberosity, I found that it is a come back reasonably on when I put the proximal screw, proximal locking screw. Now you can see there is no displacement, like there is no gutter tuberosity. Then I thought that no point to open it up and do anything. It's holding up very nicely. Even the lateral view, it doesn't go that bad. So I did not fix the lateral, what do you call the gutter tuberosity. So I left it like that way. But if check X-ray, you can see the little bit of displacement of gutter tuberosity. Then I thought that it should have been fixed up. So I was cursing myself. But after 6 months, you can see the fracture heals quite nicely. And there is nothing much to put it that way. And there's a movement of a shoulder, the kind of, there's a lack of extension of the elbow. Now, 4-part fracture, sometimes you need to fix the gutter tuberosity, like this kind of fracture. She's a husband of a matron of the orthopedic hospital. And she's quite a far distance from me, and they want to have a kind of reverse shoulder again, because nowadays it's very popular in England is reverse shoulder, because they found it's a hemiarthroplasty is not as good as they thought 10 years ago. So she is not very keen to have a shoulder. So I said, I'll try. If it doesn't work, then you can go back that way. Similar way, prepare for the distal part, given, and this, and my aim will be as medially as possible because the gutter tuberosity, quite a big chunk is down there. So I prepare to go to the medial side as much as we can. We are made down there, and then measurement of the nail, and guider goes in. And when this nail is going in, there is a bit of kind of displacement of the fracture. And I tried to reduce it back again, but it didn't work that much. And then I put the tie wire in, and then get it towards it exactly same way. We can put it on with the fracture down there. So I reduce this one, saying gliding wire, and then put it on the hook down there this time, because I can see there's a fracture on this part. There's a little kink down there. Rather than further displacement, I put it down that way with the hook down there, and then through the hook, proximal part I fixed with the one other wire, and distal part with another wire. So is that way I put two screw, one for the proximal fragment, one for the distal fragment, to a leg screw, and that's come out of these positions. That's the X-ray. After 1 year, he's doing very well, and that's the movement of his shoulder. This part's a 4-part fracture. Again, is a valgus impact down there. I don't know, people will be doing possibly Philos plate or some things, but I fixed exactly same. Impaction was released with this lever after doing the preparation of the distal part, and then I got the whole head back in the good positions of the glenoid side. Once I head that way, then my aim is to stop that my exchange tube that way, because that will be my nail position down that direction. But my bent tube guider goes, as I said, that it doesn't matter. Matter is how much, which position I put my exchange tube. So I took that exchange tube out and put the straight guide over in. I put them as far medially as possible, and the nail goes in. So that's the tie wire goes in. Now this get up towards the front. Exactly same position. I put this gliding wire down there, make an incision down there, and then I put the hook down there. Again, you can see there is a possibility of the fracture down there. So I avoid any kind of fragmentation. So I use the hook, and then I use the reduction wire for this reduction, exactly same process as I showed in the plastic. And then I put the two threaded guide wire for the leg screw. One goes down there, and another one goes down there. So that's two thread wire. Once I took everything out, it looks like this. So after fixation, this is a fixation, this is a post-op, and that's about 1 year after. There's the incision I made it, and there's the movement he got at the end of the operation. So the 70-year-old female also, the split fracture of the head. Again, you'll be thinking I'm a madman to taking this for the kind of nailing, but it can be done. It was exactly similar way. I fixed it that way, and that's the result is that. So that's that my proximal kind of head humeral fracture. Should I stop in any question or anything, or carry on?
Yeah, you can stop sharing the screen for a minute. Yeah, Mr. Haldar, you can stop sharing the screen. Okay. Yes, Sergio, any comments upon this reduction techniques and saving the, especially those bad 3-part, 4-part fracture where he has used the retrograde nailing? Yes, comments, please.
Shiva.
Yeah.
See, I have, not only I am very impressed, but you see, I wrote down so many things to comment upon that we could be here more 2.5 hours only discussing many things. You see, I have some things to say. Can I say something?
Yes. Yeah.
Yeah, okay. So see, sir, first of all, I'm very impressed. Congratulations. The first thing I want to mention is this, sir. Congratulations for your documentation, because I know how painful it is. My life is dedicated to orthopedic documentation. I am not exaggerating. I do it every weekend for 16 years now, and I know how painful it is. So congratulations for that. Well, I have many things to say. I don't want to talk a lot, but I think that there are many things, many straight points, especially for the youngsters who are seeing this. The first one is I fully agree with Dr. Excuse me, sir, your name is Dr. Halder. Is this Halder?
Halder. Yeah,
yeah, Halder.
Call him as Holder because everybody in UK calls him as Holder. Holder.
Yeah. Okay, Holder. Okay. So you see, sir.
You can talk freely. Don't bother.
Okay.
Because when I did the gamma nail, everybody criticized me. It doesn't matter. I can take. You can talk freely. Don't worry.
No. Okay. So see, no, I just wanted to be sure about your name, but I know your name. So see, first point, as I have been saying to my Indian friends for 10 years now, removing an antegrade nail is a nightmare, and Dr. Halder, he used the word nightmare. So this is important for people to understand the importance of rotator cuff. And doctor is putting here now rotator cuff out of the game. This is a very important point. See, the second point, it's very important to know how to position the patient in the table to do traction and counter traction. And this is something very important when you do a Philos plate, when you do an anterior bridge plate, when you do the antegrade nailing that Shiva does, and when you do your retrograde nailing. So the youngsters, and there are many seeing us here, they must understand that proper positioning of the patient is very important for you to not only to be able to fix the fracture, but to protect many important structures like the eyes of the patient, the mouth, the nose, because I have seen problems with the face of the patient during the surgery and very bad complications after that. So this is important. But I have two things to say, and then I would like Dr. Halder to speak. First of all, I'm very impressed, and I was thinking in the beginning, well, how does he does the reduction? But I understood that you use basically many things that we use in open approaches with Philos plates, like putting a key wire and bending a key wire to reduce the varus position. This is very important. But what is really calling my attention, sir, is this: whenever you have to remove such implants and you have that device that opens in the humeral head. So after 1 year, 2 years, or I would say, imagine that it's a shaft fracture and you have a non-union, how difficult would it be to take it out? This is something that I really would like to know.
No, it is not that difficult at all. Can I tell you at the end of my talk? It will be easier for me to end the talk. Then I go back to my instrumentation, the instrument there, because at the end of the tri-wire, there's a bulb end. End of the tri-wire is a bulb end. So there is a prong down there at the end of the distal end. It's already protruding out a few millimeters. So it is exposed outside.
No, you see, sir, as long as Shiva allows you, I would love to see you. Just a very small comment for everybody to understand, because there are many people seeing it. You see, whenever you put a synthesis, you must remember that someday you may have to remove it.
Oh yeah, and everything goes in to come out.
Yes, but this must be in our minds all of the time. So the thing is, I am very interested in understanding how do you take it out. So you are telling us that you have some slides about it.
Yes.
I don't know.
Sergio, this tri-wire have a small ball at the tip, and he has got an instrument which holds them, and you can pull it. All the three wires come out together. He has got two instruments. If one fails, he has got another instrument where you can hook the ball and pull it out. There are two instruments he has designed. One is just which like a screwdriver, which catches the ball and pulls it out. Second one is like a hook, like the hammer, which pulls the nail. Similarly, he has designed it. So you insert just above the ball and just pull it out. I have done one removal of such wire. That's why I know about this.
Yes. Okay, but sir, see, in the humeral head, sir.
We are not ending without you getting convinced with that. Subhash, if you can go to that presentation somewhere, you can just go and we can come back, because it's better
Okay.
that we understand the technique properly, then we can proceed further, because the further presentation is also on the similar line.
So should I carry on doing that, or at the end, if I can find it?
Okay, you have to find it. Okay. Then you can carry on.
Not in this presentation now.
Okay. Then you can carry on. Thirumalai, you want to add anything?
Yeah, just some basic questions to Dr. Halder. It's an extraordinary presentation. I'm really amazed. Most of the X-rays you have shown would have gone through arthroplasty in our hands.
That's true. That's true.
Yeah, congratulations. We learned a lot. Basic question: how do you position in supine position, then go behind and put the nail? Is it prone position not easy than supine?
Well, I never tried prone, because the reason is that this is majority of the old folks.
Right.
If you put prone, that's not a very good idea for them, not the anesthesia point of view.
Okay.
If the person had injury, chest injury, pelvic injury, is not ideal for them. So supine positions, no problem to me, and no problem to anesthetist. So that's the reason.
You bend the elbow like this and go behind, or turn it?
Go behind. Now, in the side. Just forget about fracture. I'll have 1 or 2 slides at the end.
Right.
I'll show you as it goes by. So what is the position? Distal part of the preparations, forget about the fracture. Preparation is on the lateral, not the epi view, the lateral view. So easily you can do that. And
the proximal locking screw, is it guided by a zig or a freehand?
Oh, it's freehand. Because the jig, it simply doesn't work in a, if you go more than 10 inches or something, it simply is always deflect. And that is such a small hole, is a 3.2 millimeter hole. It doesn't work. We have tried many times before. Freehand technique much easier, less time consuming.
Excellent, thanks.
Sir, can I ask a question, sir?
Of course.
Yes, Sergio.
Okay, sir, and concerning what Dr. TMS was talking about, the greater tuberosity, I saw that when you were putting one of those cannulated screws, you were a little bit inferior. And I was really worried about the axillary nerve, especially because you were working a little bit posterior and not anteriorly. So having said that, what are your concerns about not damaging the axillary nerve when putting those screws in the greater tuberosity? This is very important.
Yes, you can say that that's a concern, but axillary nerve goes to is a neck. Mainly is a neck of the humerus. Greater tuberosity, what I fix it up is on the top of the greater tuberosity, first one, and second one is slightly down, but it's far away, because when your axillary nerve comes to the much more lateral side, it's become much more fragmented fibers. It's not that it's shrunk down there, so it doesn't affect that much of this your axillary nerve.
Okay.
So I have not come across any problem on that point of view. Because,
okay, sir, and before Dr. Rajiv, just a very important question. I have a lot of experience in rehabilitation proximal humerus fractures in young people and in older people. But in your case, how do you manage? How soon do you start rehabilitation in young? But I'm talking not about the shaft. I'm talking about the proximal humerus in younger patients and especially in older patients. How fast would you do it, or how many weeks would you keep them in a sling, 1 week or even 2 weeks before starting rehabilitation? What are the protocols in your mind about this? This is very important.
No, it's not mine. It's a protocol is set up already.
Okay.
If it is a two-part fracture, he will start the active abduction himself with the poly sling. Two-part fracture, active abduction with the poly sling himself, no rotation until he got a 90-degree rotation, 90-degree abduction. Then he start rotation, not before that. So that goes about a month at least for the person. Those who have got 3- and 4-part fracture, it doesn't matter irrespective of their age, he had to have assisted abduction with the elbow, with the own hand, 5 times in every hour at home.
But how many days after the surgery, sir? How many days after the surgery?
Straight away.
Huh?
Second post-operative day. Second or post-operative day, as long as the patient comfortable.
Okay.
And second or post-operative, just assisted with his other hand, put the hand in the elbow, as you can see my hand, it goes up like that way. And the 5 times every hour, he will go to do himself, no rotation, until he get active abduction. After 3 weeks, he had start active abduction. Then it start, when he goes active abduction and 90, then he start rotation to going back or head or back of the back.
So you start this abduction 2 days after surgery.
2 days, yeah, passive abduction with the assisted hand.
Okay.
With the two-part fracture, active. 3-part, 4-part fracture, passive abduction. Passive with the other hand.
But just after surgery?
Just after surgery, yeah.
Okay.
Just after surgery. Because we already fixed it. That's nothing much you can lose. If you don't start with that after surgery, it is going to go stiff and stiff.
Sure. Yeah, absolutely. Absolutely.
Yes, I think we can continue. Sergio, I sent the picture of the triflanged wire on your WhatsApp. You can see the back end of the wire. I just sent a WhatsApp picture, Sergio. Yes.
Can I ask a couple of questions?
Yeah.
Can you just ask?
Yes, Rajiv. Yeah.
Hi. Wonderful magic there, sir. A couple of queries. You know, you had an initial reaming track with a wire bent. Then you put the straight wire in. Then did you ream further on to put your nail in? Because otherwise you would have a distraction element because your track changes. So
No, that's
trick,
right.
is there a trick in there?
No, yes, Rajiv, a very good question. What happened is my guide wire goes to medial side of the track I created. All right, medial side. Now, if it is a very 80-year-old woman, I don't ream it. It's very soft, it's go like. If it's a 30-70, then I ream it again. Then I mean, there's no doubt of that.
You can distract.
Yeah, that's a distract.
The next question is a very technical question. You have these the flange wires coming out. Do you control them in a direction to get a best purchase of the head, or is it just they're predetermined?
Because 3 holes in the nail is predetermined.
Just
if the one wire suppose goes outside the head, you pull it out and
couple of X-rays had one X-ray actually had a wire coming out.
I was trying to point it out for that bit, but that is still inside the cartilage. But even so, if you think that way, you can take it out and cut a short to 3 millimeter and put it back again. Yeah. No,
can you rotate the head? Can you rotate the nail a bit and reorient?
Because in a transverse plate lying over the condyle, you cannot do.
You can't do that. The last question. The last question, little observation is, you know, all your tuberosities. Now, all orthopedic surgeons have gone from being bony to soft tissue to bony and soft tissue combined. Now, the slight worry that I have, if you look at all your X-rays, that the tuberosities tend to melt off because we do not have any, soft tissue anchors on these osseous elements. So maybe a little thought process of adding some stitches along, since you're opening them anyway. Stitches into the rotator cuff, which could anchor onto your,
but that
would prevent the migration later.
Yeah, proximal fragment already attached to the rotator cuff, already attached to the proximal fragment.
Yeah, but when you start moving it, there is always a distraction force. Sergio will come up on that.
Yeah, that's right. Yeah. Right.
So that is my
sir. See, the thing is, I'm really enchanted by your technique, but what Dr. Rajiv was asking, I was thinking about all of the time when you were speaking. The thing is, just to make a comment, when I do lectures about proximal humerus fractures with open approach, what I have been saying for 10 years in India Ort and what I do, and I have already presented a lecture in Nagpur in Masterclass 2017. Shiva was there in the audience. The thing is, you must always besides any implant, you must lock the greater tuberosity on your construction with ethibond sutures passed through the posterior superior cuff, and you must lock them. And for safety issues, I don't lock them on the holes of the phyllos plate, because I have already seen these holes, these sutures being cut. So what I do is that I lock them in the shaft for safety. So I fully agree with what Dr. Rajiv is saying. This is a safety procedure that I learned 15 years ago. I teach it all of the time. I think it's very wise. And this is something that I would say it's not possible to be done in your technique. And it's not a coincidence that, pay attention, everybody, in spite of the very good final clinical results that Dr. Halder has shown, in 2 of his cases, there was in the 1-year post-op X-ray a backup of the 2 screws on the greater tuberosity. And this is very common to see, because as Dr. Rajiv has said, the distraction forces over the greater tuberosity and the humeral head, they are tremendously big. So this is why, personally, I don't use screws, but I only do transosseous sutures. And this is what Dr. Rajiv is asking about, I'm quite sure. The problem is that in your technique, sir, it's not possible. So I'm not saying it's wrong. It's a lovely technique. But see, what we do in a formal phyllos plate is a big approach. We have to see everything. And what Dr. Halder is doing is almost like I would say, is almost like the idea of a percutaneous fixation, I'm quite sure. So I would say this is something that is not possible to be done in Dr. Halder's technique, I'm quite sure. But in spite of that, if he has good results as far as the clinical results, they are okay. But just to mention,
that's fine. What I'm saying that I got 17 my colleague, 4 of them are upper limb. Here's a colleague here, and they do the open reduction, like as you say, or osteo fixations. But after 1 year, more than 50% get absorbed. So less involving with the greater tuberosity. If you try to go the rotator cuff, that is vascularity, you're going to damage that way. If you're going to entangle with that abdomen, what kind of suture you put it on? You better to leave it as it is. Before that, the Rockwood book is say that you got to stitch it up. Nowadays, nobody stitch it up the greater tuberosity any further. Sorry, my rotator cuff any further. So if you got to entangle down that way, more you involve with that, more you devitalize things, and more you get a problem. You have to have a osseous bone to hold with the upper end. So it doesn't matter what kind of osseous put you do, as long as I'm quite happy, as long as the bone bait which attached to that hilt with the head. That's my whole idea. Let the go. It might not get the full function, it doesn't matter, but I have seen 50% cases get absorbed. Nicely reduction done, nicely fixed done. You have an X-ray the 1 year, there is nothing down there. So that's the thing. When I do here, I did 900 cases of 970 myself, because nobody else is done, only thing me done. Because seeing my result, they said that better to you do that rather than we do the thing.
Sure.
So yes, less involvement is better. More you involve, more you communicate fracture, more you that way, you are in a trouble. So that's my policy. So that's the way I do. That's what.
Yes, I think we can proceed, Mr. Haldar. Yeah.
Okay. Thank you.
I think now you are taking humeral shaft fractures.
Now, so let's see what happened. The proximal humeral fracture is that this is that worst fracture of the humerus. Is if you don't fix it up at the beginning, you're going to regret it in your life. I'm telling you now that way. This is the woman. They criticize that way now 2 years now. Doctor did not do anything. GP sent me to Mr. Halder, can you do something for that? It is too late. So be careful. If you have got a proximal humeral fracture, please do some things if you want to do in the first time rather than the leaving behind. This is a comminuted fracture. You can get diversity also broken down there. So multiple fracture. You can fix it like that way, retrograde way, with this kind of fixations, as I explained you. And that is that post-operative, that is the fixation after that. And get the result of that. So that's the way I do that way. This is that kind of 58-year-old female patients treated conservatively. You can see that this is that first time is treated with the humeral brace. Humeral brace is a wonder of the world. Now it doesn't work at all, but everybody loves it. And then you put this POP over the shoulder, and you can see the whole head is rotated posteriorly as well as the inferiorly. Now they said this time, now refer to my clinic. And then I said I might have to open it up, but I managed to do without much opening up. You can see that I forget about this big third fragment. I try to fix it up as much as we can. We managed to try to rotate this one with the threaded guider, which is not here. I'm sorry, I couldn't say that. I couldn't show that thing. So give the traction that way, go as far as medial as possible, and then extend tube down that way. Then put the extends tube up to here. Now, Rajiv, you can see that my extends tube gone further up, so that it doesn't need a rimming of that further. When I give the bent tube guider to straight guider, so that's the goal. That's my straight guider. That's my nail position already maintained. So once I had that way, then measure the nail. And now with the why I see all over the fracture side before I put the nail in. Now, if I'm going to hammer it down more, I might bend it that way. Before I doing that way, I just pull it down a bit more and then hold it down that way without having any trouble. So that's the way I put it down. Humeral nail to this 10 millimeter distance from there. Tri-wire came out, and that's the distance we made it. And that's after fixation that way. I didn't open up, even though it was more than 4 weeks old. So it's the best way to fix it up the beforehand. Fracture shaft of the femur, it is, again, anybody can do the conservatively. This is the conservative treatment was done. The poor man, after 1 year, it fixed its union. In England, also in India, now be careful of having this kind of treatment. If so much high velocity injury you're having, if somebody has got a fracture like that, or somebody has a fracture there, it will be extremely difficult what you're going to do. And in England, rather in Great Britain, we are very concerned, those who are above 60, about this kind of cancer business. Mammography every year, colonoscopy every 3-4 years, and this prostate screening every year. It is mandatory. You have to do it after 65. So everybody thinking of some day, some stage you have to have a fracture. So if you got a osteolytic lesions somewhere around there in a malunion, you're in a problem. I'll show you one case then. So I usually fix it up. So this kind of fracture is unstable fracture. I prepare the distal end. Now my whole idea to not to cut this end, not to rim this end at all. This is the most unstable. And if I'm going to go the rimmer goes down that it will be rimming that way. I'm trying to avoid rimming this medial part as much as you can. So you can see here, I use the bent tip guider without any kind of what we call the flexible rimmer or my exchange tube. On the way, I managed to put it down on top end. Once I rimming, I get to careful of the rimming that. I try to avoid the rimming that way, so I just press it down that way. And my conical rimmer, 7 millimeter very conical rimmer goes down that. Once I just pushed it down that way, then I start rimming of that position. So I try to avoid that much rimmer. And again, and go that way, you can see how far bend is gone medially. That is not my concern. My concern is this point. So my rimmer will go up to there. So that point is go, and then I take it out, and then put the straight guider goes in. Once I get to there, now this Rajiv, again, I'm saying that now, as because it's a quite a strong bone down that way, I had to rim it with the straight guider after the head where I'm going to go to my nail goes down there. So I rim that way, exchange, then I changed, measured that nail, and then I put it down the nail in. Now, always happen like that way. So this, unless you see the things, you always get that way. Once I been invited to show the nail of this one in a hospital, and that surgeon is so experience is taken over from me and Mr. Tatu. Mr. Halder don't have to see all the time like that, we just hammer it up. So he was hammering it up and I found the nail is not going anywhere. When you see the X-ray, this nail goes out and its guide wire is bends like L-shaped bend. It's awful situation and have got a fracture. So you have to open up the fracture to cut the wire and pull that nail and wire up. So try to avoid that bit. I'm going to make careful that I'm not going to hit that medial side that much. So I try to push it down that way, release that bit. Once I release that bit, I release that way. That's the most important steps any kind of junior. If you're going to say, be careful when you have got this kind of fracture, saying without saying, you should not pass that nail through the fracture side. Now, when you go to the top end, even I have to ream it up to this top end, still the guide wire is getting bent. So again, if you're not careful, if you don't see the things like that way, if you're going to hammer it, you're going to bend it. So I got to take it down on the guide wire out without further any kind of problem, because this, if they're going to bend here, I'll be real problem. So I take the guide wire out and put this nail back again in its positions. It is slightly laterally, but it's still better than the having a bit of problem. So I can see that it's good. All right, now we can see there is a bit of destruction down there, but it helps when you have got the tri-wire without any tri-wire. This is the tri-wire, no distal screw. I put it on. Sometimes I don't put the distal screw in terms of fracture to have a dynamization of the fracture. That is the unit. That's after 1 year, fracture heals. He migrated, I think, Australia. So I had to take the nail out. So fracture distal side of the humerus, that is the very challenging things, but it is now mandatory to do these 2-column fixations. It's very popular, it's very effective, very good, no doubt of that, but you have to got extensive opening up, you have to do the things. That gentleman that way, this is that X-ray was done, 6 months, still possibly not healed, but I'm sure he is doing quite well. But that is the one nowadays is standard treatment of distal humerus. So this distal humerus, big butterfly segments, what you're going to do, you're going to do the 2-column plate, but I can fix it up with this nail. And with the only small incision down that way, without any opening up that much, that is the result I will give you that way. And that's that time angulation is much better rotational stability than your 2-column fixation, what I believe. And that's the way we can fix it up. This is the big butterfly segment down there. Now you're going to see that, Mr. Halder, it will be mad things to think of that, making a hole down that way, so near to the fracture, to make the hole. Look at this. This is the positions what TMC, what you are looking for, that how my positions is that way. This is the lateral position of it. And because I don't look at the fracture side at that time, this is the position of the patient. I make incision down that way. These are my positions. That the hole I made incisions because I forgot the fracture. This is the hole I made it. And that is that boundary I made it. This is the hole. And that is that, you can see there's a fracture. That is that whitish bit. That's the hole I made it. And I clean it up nicely. And that is the reduction things. This is not the patient, this is nurse. I just show you how to do that thing. That's the deduction technique will be done that way. Somebody is going to give the traction from the top end. And even you get a good deduction, there's more likely it will go to the posterior angulation. So to avoid the posterior angulation, I always use the hammer. My assistant will, one of the assistant will be always put the hammer on when I put the reaming or nailing. So one person will be pulling out that way, one person will be holding that way, and I'll do that. So I need 2 resistance of this kind of fracture. So I reaming that way, my hammer goes down that direction, and this is the way it positioned down that way. And when I put the reaming on, each time reamer goes to the fracture, the hammer is gone. Then I'm measuring the exactly same way I measure as leaving that flexible reamer in a position to keep the fracture reduced. And then when the nail goes down, make sure that fracture reduced position, hold the hammer on, no posterior, the full flexion of the elbow will be down there. And then tri-wire comes out. This position, I don't bother that much of the either medial or lateral, as long as the head, there is no fracture down there. So I don't concentrate that much to go to the medial side. So that is the fixations at the end. And that is the result you will give after 6 months. And that's the movement of the elbow you get. There is a bit of lack of extension of the elbow, but she doesn't bother that much. I usually tell them that there may be a lot of extension at the end of the operation. So this is an 88-year-old woman has got a canine operation long time ago. Now had a fracture down there. This is the fracture going up to that way. It is extremely difficult to take the nail out from the top end because it's the osteoarthritis down there. So I'm going to make a hole on the distal end. She came from long distance that nobody has got any clue what to do because you cannot put the plate down that way. Such an awful kind of contour of the humerus at that time. And you cannot put the two-plate fixation as well. So she traveled for a long distance. So I had to open up and hammer it out, this nail up, and fix this retrograde nail. And at the top end, I put the 2 proximal screw, not 1. I made for her for a 2 proximal screw. When I added a screw, I put it on. And that's that, you will get it after 6 months. So this is the most awful fracture. This is exactly goes to the other radial nerve from the posterior to anterior. We have to open up this fracture and at least to not open up for the fracture reduction, you have to open up to see the radial nerve. So how I do the radial nerve, I leave the patient down that way and make a hole and just boundary and just make a hole down that way. This is that kind of hole I made it, the oblique fossa, then put the patient back, her arm over the chest. This is a lateral epicondyle. From there, 7 centimeter incision, I made an incision down there on the lateral side. That is a junction of the flexion and extensor group of the muscles. And just carefully dissect the flexor of triceps and biceps muscles. And you will see that whitish one big rod cord coming down from posterior to anterior. That is the radial nerve and is very superficial. Once you see the radial nerve, you just secure it with the weight tape with the normal saline and hold it up with not ganging on the clip down that way. You must have a very loose and hold it in a towel down that way so it doesn't have any kind of stretch of the nerve. So I secure that way. Then I put the same incision, I put that 2 clump. You can see that the 2 clump, I got the same incision, the same direction going down that way. So if I'm going to go roughly, I'm going to have a crack down there and going to make a third parietal segment unless I make a bigger incision to clean it up that way. So what I did here, I just hold the 2 hands like that way and just jiggle it up with to and fro movements, slowly. And you can see that this kind of movement is going down that direction and come back very nicely, the reduction. Once I have got the reductions, it's very good positions. And once this reduction, the next all operation are stereotypes, just put it down that way. Extends tube, straight guide wire, and then the nail comes in. Always you got to see the nail at that level of the fracture, which I do, and then put the nail in, and then fix out the lather. That is the fixations of that, the incision that done that way, and that's the fixation and the end of the 10 months of this operation like that. So yes, sometimes I have to open up if you have got any question of radial nerve problem. This one, again, my colleagues is saying, Mr. Halder, if you're going to do that things, it will be a nightmare job. Should we do that things? No, people will be mad if I'm going to try to fix this one, a kind of intermedullary nail, especially the retrograde nail, but you can do the things, you can do it. So exactly same position will be like that way, make a hole. This is the fracture. You can see there's a fracture, epicondyle goes down that way. I made a hole down that way, that is fracture by the side. Very carefully, you ream it on that way. And once you ream it out that way, they put the nail inside. And this is the nail goes inside. I made a little kind of crack here down. That is my iatrogenic fracture. I made it down. It doesn't matter that much because this plate holding up all fracture all like that way. So this buttress plate, transverse plate, holding up every single fragment. And that is 6 months after the operations. And that is that kind of triangular base of the nail concepts for that. That is a movement Over shoulder, again, there's a bit of lack of extension of the elbow. So going back to complex fracture, 45-year-old female is a bit of alcoholic type. She have lots of combination fracture. This is the head of the humerus is lying down there. You can see there are lots of fragment down there. Anyway, I took it down there. I managed to reduce reasonably all right after the fixations. I made a little incision down there. And I put the one threaded guide wire. I put that your head back at reasonably good positions. And I fix it off with the ventive guide wire goes inside. That is the lateral view. It should be much more on the medial side. And with this exchange tube gone in the bent part of the wire and exchange tube out. Measurement done as normal. And this flexible reamer goes up to the nail. As I say that this is a quite young woman, so I get to go with the flexible up to the nail part area, then nail goes in, let's come out. Now, she took the discharge on her own because she cannot stay anymore further. She needs some alcohol. She took it down. She didn't wait for the check X-ray. But a week later, she came back with this. She fell again. Like that. So I had to take her to the theater back again. So I had to revise that operations and putting an added one screw in the posterior end. And she promised that she will not take at least 2 weeks alcohol. You know. But she was a good girl. And this is the 1 year after she came back. And she did very well. So she was a good girl. She listened to me. Now, this is that 52-year-old man. Is a bag of bone down there. Many people will with CT scan, MRI, all sorts of things. He will do the things. But in my hospital, if I go to CT scan, MRI, I have to go 4 or 5 days. I have to wait for that because it's not a private hospital, a national service hospital. So many other people are queuing there, that kind of investigations. So I don't do that kind of thing because I can see what I'm going to do. First, CT will be scaring seeing our MRI with so many fragmental, although it doesn't give you that much information because I'm doing the operation in 2 planes. So I know what I'm going to do. That's I told the patient, look, I try to reduce it as much as you can, as long as you can get it towards the heel up, reasonably good, better position, that's fine. So he agreed with me. I go back to the theater again as I prepare the post distal part, as I said before, and I lift it up with the car first lever. I put it on, I lifted the head of the humerus, and that's reasonably articular surface. I got it, and I was happy with that. And then I put this ventive guider in the medial side as much as you can. Then exchange tube goes in up the mid part where I'm going to put the nail in. Then straight guider goes in. Then exchange tube, leave the exchange tube as it is. We measure that nail, and this straight guide wire goes further in to avoid any distraction. Then I go to reaming back that way up to the head of the humerus because this with quite young people, quite a good quality of the bone. So I had to put it on that way. And then better tuberosity is slightly displaced. Now here is that slightly displacement down there, as because so much combination down there, we are saying that I'm not going to disturb that much of things. I want to heal it up that on the head, and future, if you heal it up, then you can do any kind of replacement if you need to do that thing. So I just having a fixation like that way. This fracture is heal up after 6 months. It's doing well, very well. It's better towards the heel of reasonably good positions, and you get a good articular surface of the head of the humerus. So what are you going to do this one? This is another one. It's completely bag of bone. It's all shredded fragment in the upper third of the humerus gone, and it's like a ball rotated different directions. So again, exactly similar way I did it. Forget about the fracture side, just prepare that distal part as you are doing. Now they're going to do that thing. They're going to thread guide wire goes down that way. Just try to elevate the head as much as you can. When I try to do that, you can see that the traction about the shoulder joint, but still I cannot do that much. So from there, I had to use the lever to help another help. So I put the lever down that way and lift it up. Now you can see that the two lever and guider, how beautifully I managed to get the head back in the positions. So as long as I get happy with that, now whole things depends on my assistants who is helping this to this guider and threaded guide lever. Once you have that thing, that's no problem. It's just simple stereotype, goes to the conical reamer, go up to the nails place, and then take it out and put the straight guider in, measurement of the nail, and they see the fracture side, and the nail push it out that way, and that guider out to try or goes in, and then let's go. Now exactly same thing is quite a get a diversity fragment down that way. I made a hole down that way as I did before, and when I did that way, you can see that is a fragment started. So my aim will be to do to the proximal fragment, which is the most important one, and then the distal fragment, put that way. So 2 screws, I put it on that way, and that's at the end of the fixations. That's the result after 1 year. So this fracture, you can give the result of that. Now, those who are doing this conservative treatment of this kind of fracture, but again, I'm saying again and again, be careful. Is life of the woman get destroyed, or the person get destroyed. This is the 8 weeks. This is the 13 weeks, and that is the 18 months. Now look at that, what's happening down there. She had a fall again. Now she got a fracture. She got a segmental fracture now. That way. Now when this patient's presented, usually we have a 1 hour trauma session, 8 and 9 o'clock in the morning. 50% of our 17 consultant unit groups, at least 50% present down there. And junior doctors is presenting, oh, she is unpredictable, she is not resident, she is not coming to the clinic. All sorts of rubbish things that telling that putting the finger on a patient side, they are not suitable to do any kind of treatment. So they put this, what do you call this, humeral brace, wonder of the world. I said, look, you have already damaged the woman's life. So months you haven't done anything. You should have been done beforehand. Now she had a fall. This brace will not do any good. So they said that you have to take over. So I took over. I said, look, I'm trying to do something. If it does work, no, fine. Again, I just take it out that way. I did not open up. I tried to ream it up to the fracture side. Then I made a little hole, make a bit of hood, rotated back in a slight better position because it's so stiff that thread. And I put the guide wire in, and then I ream it up to this nails positions, and the straight guider, bend guider out, straight guider put it in, measure the nail, and this I put it up at the subchondral bone to avoid any kind of destruction. Then put the nail in, and then put it on. This is the Rajiv. You can see that I had to cut this wire here because it was going out like that way. So I put it out that way. This is the fixations, and that's the 6 months he got it. Though even in non-union and fracture, this healing. And she was so delighted after that. She was moving her shoulder. She was doing 6 months at all. She's a miserable woman. Now she got a bit of smiley face. She was quite happy. Now this is the woman. She's the ex-professor of the university. Very good. 81. In the local hospital, she went down and said, I want my shoulder back. And now when you wonder how on the shoulder back, she's a very, very highly educated woman. So this X-ray was flying around England everywhere, and the southern part of the France as well. Everybody has their own opinion, different kind of opinion. Ultimately, she ran in my clinic. So I said, look, I will not do anything. So I'll just put the only small little hole in the elbow. If it does work, fine. If it doesn't work, you can go back to them. So I just prepare as I did, posterior distal part of the humerus. Then I reduced it back again and rotate this head, this prosthesis back to the glenoid, like that way. Then once I do that, then I fix it up with the tie, and I put a one added wire on added leg screw, put it on that way. And that is the fixation on the tray. That is the incision I made it. And that is the fixation healed after 1 year. And that's the movement she got it. She was quite pleased woman. Now, going back to non-union, should I stop or carry on for non-union? Subha?
We can take few questions now before we proceed. You can stop sharing the screen.
Okay.
Subhash, you can stop. Yeah, that's fine. Yes, Rajiv, Sergio, and TMS. Yes, Sergio, you have to unmute. You have to unmute. Okay, I'll do that.
Okay. Dr.
Yeah, I'm done.
Halder.
Yeah.
Doctor, you impress me every minute and every minute. Outstanding surgeon. This last case, I'm quite sure in everybody's hand would end up in a reverse arthroplasty. It's unquestionable. Everybody will do. Unquestionable. Okay.
Yeah.
So you see, sir, with all respect, you are crazier than I am, and this is a very good compliment. Okay, this is a very good compliment. Yeah, because see, what you have done, to be very honest, is absolutely off-label. And an outstanding result.
Okay.
This is thinking outside of the box. So congratulations. But there is one thing that I want to comment. It's not for everybody here because we have good experience, but for the juniors that are listening to us, I have two important things. The first one is Dr. Halder was very happy when he mentioned 10 minutes ago, then whenever you had a varus a fracture, especially in osteoporotic bone in varus, you have to pay attention, because if the varus is not so big, if you manage it conservatively, in 2 or 3 weeks, the varus is going to become much more worse. You have shown one case, and I have many cases like that. So I teach my residents, it's acceptable, but let's fix it, because it's going to get worse with conservative management. So the outcome that Dr. Halder has shown in that 70-year-old lady, I have similar cases all of the time. So this is a wake-up call. Let's fix it, and not, because see, this is a pitfall. From the nearest classification, it's acceptable. But when you have that situation in which the inferomedial part of the humeral head is medial to the shaft, the chances of having a varus collapse in 2 weeks, 3 weeks, or 4 weeks after conservative management is tremendous. So this is something for the juniors to keep in mind, as Dr. Halder has beautifully said. But there is just one thing that I want to ask you, sir, just as an interesting coincidence. 4 days ago, I posted in my YouTube channel a 40 minutes video about when and why to ask for a CT in proximal humerus fracture. So having said that, to be very honest, in many of your cases, a CT would be absolutely welcome for better understanding of the fracture and for better surgical planning. I know your experience, but see, this is absolutely clear in my mind. So I didn't understand if there is a problem with difficulties in doing a CT, but don't you agree with me that a CT would be, I would say, almost mandatory in many of your cases?
No doubt of that. But as I said that, yes, no doubt of that. But if this is the thing. But question is that when I do the nailing, I'll be having a 2-plane. So I will not be having that much information what I've seen already 2-plane. I know what I'm going to have it. I know what I'm going to do. I got a plan. I doesn't go like a wild or anything. I know how it's going to. There's a plan down that way. You're going to go to the battlefield. You have to have a plan. So I just tell the patient, look, I will try my best. Yes, CT scan, as I said, it is or MRI, it is the most important things in nowadays. Everybody does, everybody good. But it doesn't give me that much of help unless I open up the fracture to find out what is this fragment, what is this fragment. So I can, as I say, that with little guide or here and there, hospital have got a nickname is a gold finger somehow. Don't like that. So I can manage to pull out things reasonably all right. So that's the thing like that. And they trust me. and I have not let them down yet. So yes, but as you said, CT scan is the most important investigations everybody should follow.
Yes,
Dr.
TMS. Yeah.
You showed beautifully the fixation of the greater tuberosity with your technique. Suppose the lesser tuberosity abults with the subscap, how will you fix that?
I speak the truth, I have not done yet, so I cannot tell you really. I have not done. If somehow it come back reasonably all right. If you put the lesser tuberosity, try to open it up and fix it up, I don't know, it will be devitalized more. So as long as muscle soft tissue down there attached, it will heal up on its own. That doesn't go that much of displacement further. It is stay nearby. So it does heal. Greater tuberosities have got a big muscle power to pull it out, but lesser tuberosities does not go that much displacement. So I don't give that much of attention down there, and I never fix it up. So I cannot, I'm ignorant of that. I'm sorry.
Another question is, what will happen to the long head of biceps? Do you ever worry about that in 4-part fractures or not?
Not really. When only thing I worried about that if I'm going to my locking a screw or one of my tri-wire goes out of the head, so I got to rotate different direction to see how that tri-wire goes out or not. And also, end of the operation, you always have to flex and extend the elbow to see whether it is smoothly moving or not before closing up or finishing up. You got to do that.
I think Sergio releases the biceps. Yes.
Yeah, so the thing is, with all, well, see, the results of Dr. Halder, they are speaking for themselves. But besides that, this is something that I teach my shoulder fellows and my residents all of the time, because, and I speak this in the internet with my Indian friends all of the time. See, the long head of the biceps, the intra-articular long head of the biceps, it has 10 functions in the shoulder: pain, 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 trouble, pain, trouble, and pain, 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 pain. So I am a biceps killer for a million reasons. I can talk with all respect 15 minutes about the many reasons why I am a biceps killer. And I came to a point, and I am very mature in this, in which it doesn't matter the pattern of the proximal humerus fracture. Whenever we operated in my public hospital, in which I am the chief of shoulder and elbow and trauma team, I kill the biceps not 100% of the times, 200% of the times. I am doing a big favor to the patient. There is plenty of literature to support my statement. So having said that, with all respect, not killing the biceps formally, killing means tenotomy above the biceps pulley. It doesn't matter if you leave it alone or if you do a tenodesis in many different places. But in spite of the good results of Dr. Halder, not killing the biceps is a considerable disadvantage of this case. There is so many literature erasing about, and you see, sir, and if you want, I can show in another web meeting a lecture about it. The intra-articular portion of the long hair of the biceps is a vestigial structure from a biological point of view, like the wisdom teeth. It had a function, I would say, thousands of years ago. Now is a vestigial structure. So this is a joke we do here in Brazil. The only function of the wisdom teeth is to give money to the dentist, okay? This is a very wise joke. And the only function of the intra-articular portion of the long hair of the biceps is to bring money to the shoulder surgeon. So there is a very wise shoulder surgeon here. He's 70 now, he's much older. And he always says to us, respect the intra-articular portion of the long hair of the biceps because it brings milk to our family, to our kids, because it's a very problematical structure. And there is plenty of phylogenetical, I'm serious, phylogenetical explanation why we have to kill it. So I would even ask you, sir, I know I'm gonna change your mind, but maybe I would say thinking about killing the long hair. By killing, I mean tenotomy in the biceps pulley would be something to add. I would say many benefits to your cases. I know I'm not gonna change your mind, but there is sense in what I'm saying. So.
Anyway, Haldar is not opening the fracture. He is doing close technique and he's not using arthroscopy to remove this vestigial. Yes.
I'm not touching that God-given abstract.
Yeah, that's correct. Mr. Haldar, you have a question from Dr. Ram from Hyderabad. He has congratulated that initial part. I'll leave it because of beautiful presentation, valgus reduction, so good, calcar restoration, so many things. The question he has asked is, are there any complications like AVN, non-union, rotation, cup laxity like that? He has asked this question.
Yes, that is a non-union. I'm coming back to non-union part.
Okay,
Yeah.
No, you are using that nail for non-union. In your own case, have you got non-union?
Yeah, I've got non-union, but I revised again the same nail.
Okay, yeah. There is one question from Dr. Shashikant Ganjale from Sholapur. What is the length of the distal fragment? Because used in a case very distal. So have you any measurement that this much should be the length of the distal fragment where you can do the retrograde nailing? Nail.
No length business. As long as you got a little space for making a hole.
Okay.
As long as two condyle intact. Two condyle got to be intact and having a little space for the hole. So if the two condyle broken down, there is no good. You got to have a two condyle intact.
Yes. Rajiv, you have any question? Otherwise we can. Yes, Rajiv.
One point that we face quite often in our part of the world, especially ladies, the size of the nail. What is the minimum size of the nail you have?
The nail is 7 and 8.
The problem that you have in India is 6.7 also doesn't want to go through. So if you have already made something whole distally and trying to navigate up, is there any tricks that you have? Because the reamer jams, and I have personally split the humerus trying to put a reamer through. So do you have any tricks for that?
Oh, yeah, well, that's why I'm telling you about is nowadays reamer is very awful reamer. What you got a blunt reamer. Do you understand?
Yeah.
Modern reamer is a blunt reamer. If they can show, I got the tibial fracture. I got a conical reamer. You got a forward cutting and side cutting. That is a whole set. AO had got a whole set time. Now coming mostly side cutting reamer. So side cutting reamer has a blunt end. So you can realize that with a narrow bone, if you're going to blunt, first it's stuck down there. So it does not, you got to give it pressure and create a huge amount of kind of thermal burn, I think. So, but if you got a forward with tapering nose, it's cut both and that make it like making any kind of tunnel. You just put it like a screwdriver type things.
So all your reamers are end cuttings.
All kind of end cut. All reamers are side cutting and forward cutting and side cutting. Both. I got a set. So I'm just looking for that. I don't know why on the art they don't make like that way anymore. And I kept it that set myself. Yeah, that's a problem. So having that kind of set, you can 0.5 millimeter increment, you can do that way. So you don't have to 0.5 millimeter increment.
Yes.
Not
you can proceed. Yes. I think you can proceed, Mr. Haldar.
So can you stop coming out?
Start sharing.
Share screen.
Share the screen.
Bottom.
Fine. So non-union of the fracture humerus. Now again, it is a bit controversial. So this is the fracture treated conservatively that we can lie that way. That's a 2 years time it comes. Now it become like a ball on socket type things. It's move here, not the sound that way. So everybody will be doing the opening up and do this bone graft, but I just push it down that way. When that pushed that way is sucked in, and because it is quite mobile, you can see that it's just inside and put the nail in, and that's coming out like that way. So ultimately, in a 3 months time, there's a one year time, he'll it up. Exactly same one, similar type of things, conservative treatment. I had to open up this one. I put a bone graft down there and put it up that way. And that's a kind of fixation I did. And there's that 6 months, it heals nicely. And there's a movement, she easily get it done that. So that's a non fracture. So this is that kind of humeral fracture that is in an area about 90 miles from my place. Treated with a nail, like the Integrate Nail is a very reputable hospital down there. And then it has got a bit of pain on the shoulder. They take the nail out and ultimately gone that way. Now it's a problem, what are you going to do? So they have got a very, it's a very reputable hospital. They have got an Elijah system down that way. That is a 2 years down that way, now that way. They do the Elijah fixation. They cut that osteotomy and that called these mobilizations of the segment. And they did it quite nicely. Ultimately, when there's 5 months time, they took the laser off and original fracture remained exactly the same. And this patients is 65, is 3 years, many times have been treated. How is it going to settle down? This patient was discussed in the trauma meeting in that particular hospital, and everybody is scratching their head, what next got to do. That time there is a registrar who walked with me, and he raised the hand and said that, why didn't you show to Mr. Halder? And everybody looked at him, who is that boy come from? Who is Mr. Halder? So ultimately they sent back to me. So I opened up, I fixed out I put the bone graft on. I usually have one locking screw, I put the 2 locking screw here. And this is the fracture and movement of the shoulder after 5 years. This is a woman, is called the director of very, what they call demanding and dynamic woman, 32-year-old female woman. He was not the South Africa in a Cape Town, knocked down by a car. They put it in a Integrate Nail. And that is that nearly more than a year now, it become non-union, and this distal is about to break here. And again, then they don't know what to do. They can put the plate down there and they get another plate here. Or what are going to do that one? That's the query. Ultimately, she traveled back to my clinic. So I decided I will do the Integrate Nail. So now you can see that how difficult for me to take the Integrate Nail. I got quite a few revised Integrate Nail. This is extremely difficult to get the locate. I got scooping out the head and then managed to put the guide in, and I could not engage that structure with this nail. Is this tip of the what we call the acromion is just obstructing me. So I abandoned the idea because I'm going to make a whole elbow anyway. So I make my proper hole and then retrogradely I just hammer it out the nail. Now been problem here. You can see now what do you know? Can anybody know what's the problem here? His head is rotated. You can see that the screw is completely 90-degree rotated posteriorly. So anyway, nothing I can do now. So I have not opened it up, this fracture side. I just retrogradely ream it down that way. And that guide wire gone to the old hole. And that's my favorite kind of wire, cutting about acute angle as much. Then I just go much more on the medially and having a bit of anchor with the new tissue, bypassing this old hole. Once I got the new tissue that way, then I put it a 3.2 guide wire, what do you call it, drill bits, put it down the hole and rotation, put it back as it was before. So I put the rotation back down that way and slowly hammering down that way this guide wire in the proximal end of the humerus. And then I got it. Now the Rajiv, you can see how much now beautiful conical reamer I got it. And that's the help me to put in the new channel, even there is a hole down there. So I managed to have a channel on, this is a 7 millimeter, and that is the 8 millimeter new channel down there. So I got it down there. Then I measured that guide wire, I measured the nail, and then managing the bypassing this hole and put the nail slowly on the medial side. So at the end, I managed to fix it up that way. That's the 12-month, no bone graft, no opening up, second operations. And when she comes to my clinic, comes with the mom, she says, Mr. Halder, she is a very demanding woman. She wants to say you stay to her when she comes. I said that even the queen will not see that way. Yeah, she had to wait. So that's the movement she got at the end of it. She was very pleased woman after all, 2 years later. So segmental fracture, I usually put it down that way. I usually fix it up exactly like that way. No distal screw here. There's this segmental fracture, always have to need some kind of axial dynamizations to get it up. Otherwise you get a trouble like other one if you have a rigid fixations. And this got this segmental fracture is got a subcapital fracture as well as spinal fracture. Again, you can fix it up exactly similar way as I showed before, like that. So you get a reasonably good movement of the shoulder of the woman. Again, there's a bit of lack of extension of the L. Now, fracture dislocation of the shoulder, that is the bit query. That's everybody says it will do this replacement ball thing. This 70-year-old woman is having a fracture dislocation of the shoulder. My way of doing what I do, I make a preparation of the patient put in a supine positions. Then I make a small little nick down that way. That is the calf scissors goes down that way. What I'm trying to find out, the fractured side. So once I go to the fractured side, then I put the corkscrew. You know, corkscrew where you put this kind of hemiarthroplasty of the hip joint, you took it out, that corkscrew put it down and gradually put it down that way inside the head of the humerus. And then with the traction, contraction, pull it back. So I managed to pull the head back to the humerus. Once I put the head back to the humerus, then it's simple as to put fracture humerus, what I do. I managed to hold down the, I did the hold on the of the olecranon fossa and then guide her the fracture side. Then flexible reamer goes up to the fracture side and then rim it in the head of the humerus, straight guider goes in, measuring that nail. And again, I stop that on the fracture side and put the come out. This is the fracture, this is the humerus, that's that 1 year after the operation. And that's the movement of our shoulder after 1 year. This is that woman, she's got more than 100 miles away from me. They went to the local hospital. They are not sure what the best things we'll be doing, how the hemiarthroplasty or reverse shoulder. And she went down back home and she got a friend in Australia. She's an orthodontist, happened to be worked in my hospital a long time ago. And he told, his name is Mr. Cannon, he told to go to Mr. Halder, see what he says. So I came back to my clinic. I said, look, I'll try. I'm not sure that my reduction type, sorry, it does not show, just exactly similar way. I managed to reduce that fracture. And once I reduce the fracture, other things exactly the same, on the contraction and traction, and then reduce that two-part fracture, which is displaced down that way, and go as far medial as possible because it's quite a big chunk of greater tuberosity broken down there. And straight bend guider out, straight guider put it in, and then fix it. Sorry, up to the subcortical region. The nail goes in. Then it's like a small incision down there to push it down to Haldar. I did not do that one because so much kind of combination down there, as well as she was, I think, two, three weeks old at that time when I brought her back to theater. So I didn't want to open up that much. I just have a small incision and push it the finger and instrument and put the on threaded guider on the fracture side to get a tuberosity and put this two guider in and it come out with one locking screw. That is a fixation. So that is a fracture and that's a fixation. That is after 1 year. And that's a movement of our shoulder. Now, one patient, I have got an epileptic patient, I got a bilateral dislocation of the shoulder. They take it to the theater in the middle of the night. And this happened to my hospital, another colleague. He could not do that much reduction of what he did. This is the right shoulder. Look at that, what happened. It is completely upside down. It's 180-degree rotation of the shoulder joint here. This is the right side. And this is the left side, is where it is posteriorly rotated like that way. So he called me middle of the night, Subhash, can you give us a hand? I said, look, it will be too big job in the middle of the night. Tomorrow I've got a clinic to do. So leave it down there, I'll sort it out tomorrow. So I brought it down there day after tomorrow, after sorting out. So what I think, if you are very fond of your Chinese or Japanese chopstick, that would help me. What I did, I two small incision, I made it, two kind of lever, I goes down that way. What idea to give it a traction or contraction and also rotate it back, 180 rotation back. And it's so mobile, so different direction, it's so difficult to do the thing. Ultimately, you can see that from this one, just gradually out of it and gradually manage to get it. And I hold it with the chopstick like a forceps. Then after that, I put the threaded guider and look at that. So I managed to rotate 180 degree and hold it with the threaded guider. Once I hold the threaded guider, then job is very easy now. So as long as you can hold that positions, rotation, then other things as a stereotype, put that guider in the middle part and remit up to fracture side, up to the head of the humerus, then a straight guider and measure the length of the nail. And then very carefully, because that is quite mobile, you have to hold this one very tight positions and the nail come out. And then left shoulder come across, I just put the thumb, my posterior part of the posterior border of the glenoid and just milk it out and managed to put it back again. So that was quite easy. It's not difficult. Then again, it is same as bend guider goes in the head of the humerus, remit after this nail, what goes in, straight guider goes in, measure the nail, and then fix it up like this. And so that is that shoulder he got at the end of the day. And at this, after 8 months, what happened, he went down to the, I asked one of my colleague in physician, that at least if you can have at least 2-3 months without any epilepsy, that will be much, much better, or that will be disaster. So he managed to have a free epilepsy at least quite a few months. So ultimately, I managed to get hold of that X-ray over the 8 months time. It's doing quite well. Maybe there is osteonecrosis started, but he doesn't bother that much. So I left it that way. This is not fit for any kind of replacement of this unstable or the epileptic patients. No, that's a 65-year-old man, got a heavy patients. Now you can see that this is the glenoid, and that is the shoulder, and that is a combination of fracture. It's a challenging job what to do like that. But again, obviously, Sergio will be saying the CT scan is the best. I am sure that will be the best of the things. But everybody will be doing that way. But as I say that, as far as I am concerned, I know if I'm going to take a theater, I know what I'm going to do. First job will be here to get the shoulder back to the glenoid. Once the shoulder go back to the glenoid, hold it down that way, make a hole in the elbow, prepare the distal part as you normally do, then prepare this distal part, then go to the head. So that's how I'm going to do the things. I made a little nick down there. My calf forces goes down there to find out the fracture side. Once I go to the fracture side, I go to this mic and the corkscrew goes down there. And very carefully, with very, very soft bone, carefully, I pulled it back to the shoulder, the joint. Once I have the shoulder joint, I keep the corkscrew this time because I did not trust that he will not go back again in this location. So I left it down that position. Then I prepared this distal part, and then I managed to reduce it reasonably, pull and pushing around line. You can see that now all the fragment coming back so nicely one position. Once you have got it, you have to have a very respect to the soft tissue without doing anything, and you get everything falling back in your own positions. So once you have got that things here, everything is fine, as long as my assistants take a bit of attention to me. So then guider goes in, and it's a stereotype operations, goes down that way, nail put in, and trior goes in, and it come out. Then this one, again, I did not open up that much. I made a small incision down that way. I tried to push it back as a reasonable position as much as possible. Again, it is quite fragmented. I put the stabilizing wire, threaded wire, then put the two lag screw and one locking screw. And that is a fixation at the end of the post-op next day. So that is a fixation, that's a fracture, that's a fixation, and that's that you get after 1 year of the fixations. That's the movement of the shoulder and elbow. You get the 1 year. She lost some weight at the moment. She's a very good girl. So osteoarticulation, should I go to, this is my last session for you guys. Should I stop it?
Yeah, okay, you can continue, sir. Yes.
Okay, fine. Osteoarticulations, this is the woman about 65. She had a multiple myeloma, has a small little focus here. She is a ex-sisters in orthopedic ward. And she retired about at the age of 60. She thought she will be moving around the world with the cruising here thing that normally Western world they do. Cruise is the most important thing after having a holiday. But she cannot do that thing because they put the brace on. You can see the brace on gown that way. She cannot put the hat for beautiful dress or in a cruise they have got every night they got a dancing kind of things and down that way. She wasn't able to go down there. She is so miserable, she could not do that thing. So came back from a long way to me and say, Mr. Halder, I served orthopedic surgeons and doctors all my life. And when I need them, they can't do anything for me. So do something. So I fixed it up like that. I didn't open up, I just pull it up that way. And after about six months, it heals nicely. And so she was so delighted, no pain, moving the shoulder quite all right. And drinking it all days and cruising around the world. She is a happy woman. And once one cruise finished, every time she come to the clinic without any notice and say, Mr. Halder, I'm doing fine. So those who are not careful, those who are conservative treatment of kind of things, be careful. This is a 33-year-old woman, two children, and thyroid cancer. When she was about 20, she fractured neck of humerus. And this is malunion. Now she got this kind of problem. What are you going to do? That's extremely difficult. What are you going to do? Neither you got the integrate nail, nor you can do the plate, nor you can do anything. So they put the brace on like that way. She is a Derbyshire like that way. And after 6 months, she was getting angry and go to the clinic and said, do something for me because I had to look after my two kids. My husband go to the work. I cannot do any kind of meal for my children. That is the life I don't like to lead. And they sent it to the Mr. Angus Wall is in Nottingham. She is a shoulder expert down there. And you know the Nottingham orthopedic specialty is very good because Prince Charles operation done in Nottingham Hospital. AO has got a teaching hospital first to open is Nottingham Hospital. So that's a very renowned and pronounced hospital in Nottingham, especially shoulder department. So when this Angus Wallace saw the things, he knows the nail like that, he rang me, Subhash, possibly your nail might help this woman. So she came back to the Halifax. I fixed that nail, and this is the right hand. Now in my hospital, she's using an arm, and a little bit of smiley face she got. She's so delighted. And there's a 1 year after, she came back to my clinic, and there is no lesions. She cured from all problem. She's quite a good woman. So be careful those who are doing this conservative treatment of youngish people, because Western world is always about the age of 65, they're concerned there's some kind of problem might have with this cancer. 80-year-old man, the prostate cancer, they put a plate on. Plate is not a place for the osteoarticulations. So that's the things happening. She came back to me again, long way up. So I have to take this out and fix it up. This is the first time in his whole, at least 6 months, he said to Mr. Halder, I managed to sleep tonight quite well without any pain because he got either plaster or plate didn't do any good. So yes, this kind of fixations is so important for this kind of people. These people will not live that long, but they want to live pain-free few rest of their life. And that is the duty of the clinician as well. Otherwise, they dosing with the morphine. That's not very good things. Again, it's a breast cancer woman, just little lesion down that way, nothing has been done, now broken down there. That is the problem now. What are you going to do? It's very difficult to treat so low fracture or any kind of implant like that. So I took it to the theater. I did exactly the same way as you do the distal humeral fracture. I made a little hole down there. Again, similar positions. That is posterior angulation. I had to, by hook or crook, avoid it that way. And this is the nurse's picture. I'm showing that way. This is the way I hold it down that way. There's the traction, counter traction. I put this one on the mallet to avoid any posterior angulation. This is my guider goes in. That's my mallet goes down there. That each time the reamer goes in, my mallet down there so that I avoid the posterior angulation. And this is that every time I goes down there, I'm trying to see on the epi view as well. And the nail, you can easily kind of break the posterior cortex down there. So you got to be careful, very careful. This is that elbow, usually with a fully flex, it's not like you have to flex the elbow, but she hasn't got that much of movement of the elbow, so I could not do that much. So ultimately, we managed to put it down that way. So this is a fixation, that's a fixation. And she did reasonably well. Around 6 months, there is some kind of bony formation down there. And she's, as far as the control of the breast cancer, she's doing very well with the chemotherapy and radiotherapy. So yes, it is very concerned those who are suffering from cancer. Now, it is tempting the upper fracture in my hospital to do the conservatively. So they put this wonder of the world is a breast. They put the breast of the footing on that way. It doesn't matter. And that's the one I'm telling you what happened. She is an associate professor of this, my nearby university. Husband is a very high profile barrister and very educated family they have come from. So they put it down that way. Now, in 9 weeks time, something happening down there. Anybody can point it out.
There is a lesion proximally in the, just below the neck.
Yeah.
Yeah. And there as well. When he sent this news to his husband and that lady, their pinkish face became a red hot. And they said that why my wife's shoulder or humeral operation fracture was not fixed at the beginning. Now, what are you going to do? It is extremely awkward situation at that time with my colleague and other it is a very, very difficult situation. Happened to me, I was in the next door in the clinic also. She came back to me and told her, can you sort it out? So I took it down there and explained the look. These are the things I had to open up this one. I had to do that way, like that way. Managed to convince them, but they went down there. She made a £1 million suit to the hospital and asking for the protocol of the humeral fracture of this hospital. And he's the whole chairman down to the all the department, dancing around what's happening. It's quite a bit of money involved with that. So I managed to fix it up that way. I had to open it up and managed to fix it up that way. And as you see that I put this nail as middle as possible with a division down there, you can see down there and there. So I managed to do that way. Ultimately, that become a coin, ultimately become whole now nicely. That very close, and that breast cancer is settled down. She is quite a good woman. They settled down that way. That is the incision I made it like that. So yes, be please careful. Though you don't work in England or anywhere, so it doesn't matter. But here is very much concern of this kind of people, those who suffer from cancer. This is my last X-ray. This is that X-ray of oscillation of the humerus. This person's primary doesn't know where is it. He's very, very one of the important person in England. His name is Lord Marshal Walter. He's a very intelligent man. I'm just taking you 2 minutes time, Shiva. He's a youngest graduate in Birmingham University. He became a 23, he became a physicist. 33, he became a professor in Harvard University. When Margaret Thatcher became a prime minister, he brought it back to here, to the England and asked him to this nuclear plant for the energy of the electricity. And we are still using this electricity through his plant. Now, this person has got a cancer. Nobody knows why it's a primary, but his shoulder and humerus eating away. So you can understand that what kind of physician and surgeon involved to treat him. Now, nobody could do anything because he got a painful shoulder. He got extremely painful shoulder, and ultimately, you have been told that they cannot do anything. Then Lord Marshal says, do something for my shoulder, at least. I cannot live like that way. He says, Lord Marshal, you will live only 6 months. Then he said, live me 6 months with pain. So they have a brachial block. That doesn't have also. Now, at that time, you know, possibly you know the Reading place, you know the Mr. Copeland, he got a shoulder prosthesis. He's very, very nice guy. I know him very well. He knows me. So he was arranging a International Shoulder Society meeting. On that meeting, Professor Neer, Professor Rockwood, Professor Angus Wallace, and Green, everybody, all the cream people or the shoulder people was down there. And Copeland invited me also present my humeral lane down there. I presented down there. When I presented down there, and you wouldn't believe that thing, that Professor Rockwood and Green came down to my floor and shook my hand, says, well done. I didn't know that anybody can reduce a fracture like this. So I was feeling great. I was suddenly become a 7 feet tall man. So I was, seems great. So after that, when I coming out of the gallery, it seems I'm walking on the moon. And one man is stopped me and showing this exercise, Mr. Halder, can you do something? And I saw the exercise, yes, I can fix it up. So he looked at me a bit surprised way and said that, do you know who is he? Then I saw in the extra film is a Lord Walter Marshall. I said, well, if the Lord won the operation, he had to come to the Halifax. Because he didn't like my comment, he just walked away. I said, I didn't care that much because Professor Rock and Green, whose book is our Bible to read, and they shake my hand, so that's enough for me. So I was moving around. 2 hours later, he came back. His name is Mr. Nash. I said, yes, Marshall want to go to Halifax. So came back to Halifax. He will not come to the national service, so I got to have arranged a private hospital. Private hospital in a trauma is nothing. There is nobody does the traumas. So I had to ask my nurses, and the instrument goes down there, and he asked one of my colleague, Mr. Chapman, to give me a hand because there is no experienced register down there who can help me, and the person like that, I have to be careful. So what happened when I went down to see him in the evening, day before operation, he was telling a tales which really, really bothered me. I'm a Hindu person. I'm not a very religious man. That day I pray to God to help me, because he was telling me that text was shown to everybody, especially Charles Neer and the Professor. And if you want to have a pain-free shoulder, you have to amputations. And I was a bit scared. I said that kind of people say amputation, and I'm bringing it down here to have an operation. I hope it help manage to do that. Anyway, I managed to do the operation all right next day. It is fine. It is very well. I can fix it nicely. And within 4 or 5 days, he's got a completely pain-free. The man who was dying, now he's walking around and living forward to live. And he opened his office in my hospital, private hospital. Lady Marshall took a hotel down there in a 2-3 room down there. So great that way. So one day he's about to go home. Everything is fine. Then he called me that he wants to see me. So nurses called me. I thought that there must be something wrong, because these kind of people who got a radiotherapy, chemotherapy, his white cell count as well as the platelet was quite low. I thought there might be some infection. So I just finished the clinic and come back quick. And as soon as I came back clinic, he's sitting down there. You can see this is a Lady Marshall scarf. She will not the hospital slings, the silky scarf put it on, and about to go home. And I said, have you got a camera? I said, why should I camera? Take my picture. Whatever you present this humeral nailing, you must present my picture. So that's why I got a permission to show his picture like that. So that's it. But he went home and he got a beautiful, gratifying letter. I don't know whether he got a time to read that thing. So I will have 1 or 2 lines. Only you, with the support of Mr. Chapman, who is my helping me, willing to attend these triangular operations. I had a choice of amputations of your of trusting your myself of your new idea and skills. I shall follow, I shall forever be in your debt, and in such a time I will use my right arm. Enably, I always remember. He lived 1.5 years after that. Every Sunday he used to ring me. He's a very, very nice man. And like that. So yet it is gratifying to do a person like that, people like that. I also present this paper in Sydney, in 7th Shoulder Society meeting, and this is the best clinical paper I awarded. And thank you very much, ladies and gentlemen.
Yes. Thank you, Subhash. That was a wonderful exposure, and really everyone who has seen your presentation will learn few newer tricks which will be useful in the long run. I have heard you so many times, but every time I hear your talk, I definitely get additional few more tips and tricks which will be useful for me also. That is one of the reasons why I wanted a shoulder surgeon like Dr. Sergio to be here to see the magical hand of Subhash in this webinar. Yes, any questions from the panelist? Subhash, will you please stop sharing? Yeah, thank you. Yes, Sergio.
So see, sir, just some, I would say, some final comments. We can discuss for a lot of time as long as Shiva wants. But the thing is, it's not only about your magical hands, but it's about thinking in a different way. You see, we fix these things, I would say, in a very interesting way, but in a different way nowadays. I always try to think outside the box and find new ideas and new solutions. But you think what you've been doing is different from the mainstream, sir. You know that. So this is interesting. No, it's interesting. It's different, but give us different ideas to deal with, I would say, different scenarios. As I always say, we don't have to think like this. We have to think in an open way to see different ideas. But there is one thing that I just want to comment. You know Gilles Walsh. Yes, sir. Everybody knows Gilles Walsh, one of the fathers of shoulder surgery all around the world. He's still active, and he says, the surgeon is the method. The surgeon is the method. So if this is something that works so beautifully in your hands, you've really, with all respect that I disagree with you, is that in many cases of yours, a CT would be very welcome for better fracture comprehension. Well, sir, maybe not to you, but for the rest of us.
And I said it is mandatory to everybody. I'm slightly different from the rest of the world. Yes, I said it is. Everybody will do that. Everybody will do the things. But at the end of the day, what you get? Yeah, that's right. If you feel that CT scan, the most important thing, give you much more information, why not? I'm not saying that no. I said always yes, always yes, always yes.
Yes. Sergio, for your information, Subhash works in a hospital where there are 17 orthopedic surgeons, and 2 or 3 of them are upper limb surgeons. In spite of that, he gets all these cases.
Lovely. You see, and sir,
I've got exclusively, I've got one dedicated theater every week afternoon for these things. One afternoon dedicated. I've got a dedicated clinic for that. That's besides all other things. Every single fracture humerus, most of the time, 99% come to my side. Whenever it comes.
And see, sir, just a second. As I understood, we don't have to talk about it, of course, but you do nails in femurs and tibias as well. I understand that. So you are just like Shiva. You are a nailing man, a super nailing man.
Well, yeah. Well, that's right. You know, one of my register presented a paper of mine, and I wasn't down there. One of my colleagues down there, and one chap asked the register, "Tell me what Mr. Halder doesn't fix it. As anything moves, he nail it." So that is. comment.
Yes. Subhash, is this nail available apart from you to anybody else in England?
Nowadays is not, because that company merged with the other company, so take it off. But I already made it in India. It's supposed to launch in December, but this COVID virus business stop everything.
Okay. I think you should launch your humerus nail and tibia nail in India with whatever the company you are
already ready.
Yes.
Already ready down there.
Okay.
One of my professor in Israel, who is the president of the secret meeting now, he is using all the times his nail, and he wants to use again that nail, and he was looking for particularly. And in Japan, they're using quite a lot.
Okay. There are one or two few questions and presentations. I'll take them. This is a question. A distal retrograde nailing has been done, and the surgeon shattered the entry site. So this question from Dr. Narayan Swami from Bangalore, who's asked, sir, do you have any splintering of the distal fragment while reaming of the passing of the nail? I had one such case of splintering for which I had to open and put the encerclage wire. This is the picture at 6 weeks time. This is a recently done case. Any comments?
Yeah, it is, because what happened, you goes down there, you think of that, your guide wire goes down where? Is in this on the posterior side or anterior side. So it goes anterior to posterior. Sorry, posterior to anterior. So when you ream it, where are you going to ream it? You ream it much more on the posterior side. So you're making more and more.
Could have been done little more inferiorly at the fossa.
It should be the fossa. And nowadays, everybody in England who's done they usually use my method now, that you got to hold here. As I explained you initially, why should I make a hole? Look at this, is the most weakest part. There is nothing doing here. There's an open space down there. So it should be down, hole should be down here. Then it should be easily limit down that way.
Yes.
So
he has asked another question. Does that plate, what you are fixing at the distal end, the screws, do they work as a polar screw also?
No, it's going through the plate to the condyle. It's nothing to do with the polar screw.
Okay. This is another case. Dr. Ravindra Gavle from Bharuch in Gujarat has asked this question. 65-year-old bulky man, diabetic, type 2 diabetes with hypertension. He had fractured humerus. He has specifically written there was no radial palsy initially. Then after making entry portal, when he started reaming with a cannulated hand reamers, size 6 and 7, the reamer broke at the distal of the canal. So this is the guide where he was, this was a hand cannulated reamer. So how to remove this?
Oh, yeah, it's coming from the shoulder.
Yeah, it has come from the shoulder.
Yeah. So what happened? You had to have you have to have a bend. You know that is a guide wire. You can pull it out. This one, isn't it?
Yeah, this is not a beaded guide wire, because since he was using a hand reamer, which is not, this is fixed. So he has used a plain guide wire here.
Okay. So you got to put another thinner guide wire.
Yes.
Go inside, make it jump.
Okay. Yes.
And
yes,
then
Sergio, you have any trick for this, Sergio?
Excuse me?
You have any trick for this removal of this broken reamer over a plain guide wire?
The thing is, well, I don't know. What I think is that you cannot make the situation worse than it already is. So a lot of care, but see, well, a very difficult situation. What you can do, it's something like, do you know the Wagner osteotomy from the hip? So you open a very small window, is a very, I would say, small, a time-consuming job, and then you would come with a hammer, but very delicately, because you know we had one case here 20 years ago. in my university, in my ex-university, and people had this problem and they tried to take it, and this humeral piece exploded. It was a tragedy, and that case was known as the TNT humerus. It's a joke, you know, the TNT.
Yeah, TNT.
Yes, an explosion. So you have to take a lot of care. So, you know, the only ideal solution for these cases is prevention. But it's part of the game. You know, it's very difficult to handle.
But Shiva, can I say one more trick? I'm tell you. You just make a hole roof of the oblique fossa as I was doing the nail.
Correct.
Push it up.
Yes. Yeah, that's correct. For the
I
want of time, we'll take it further. Yeah.
You know
He
that.
made
You know
a
that.
hole
You know
in
that
the.
I similar way I removed that integrate nail. My integrate nail, I'll show you that. Can I go to my presentation? Then I'll show you.
That's fine, sir. We'll discuss this part because we are already about 30 minutes away from 8 o'clock. So he used a owl to make a hole. Then he used a rush nail to push it up. And once it came at the fracture site, he took an incision at the fracture site and took out the fragment. The problem he has faced is after he removed this broken piece, he could use only a 6 millimeter nail, and while locking, the bolt, distal locking bolt head broke, and he was unable to remove the bolt part, the shaft part which was inside the nail. So he just did another locking with another 2.9 millimeter bolt and left this, and unfortunately patient has a radial nerve palsy at this stage. So his question is, post-operatively, patient has wrist drop with intact sensation. He has done yesterday only this surgery. Should I go for immediate radial nerve exploration, or should I wait for spontaneous recovery? That is a question. Yes, Subhash, what you will do?
I will open up. I don't. Some people say that wait and see, wait and see what?
Yeah, because pre-operatively there was no radial nerve palsy. Now it is totally after the surgery.
If it is damaged, still the fresh damage, you can do whatever you like it. But if it is not damaged, you are not losing anything.
I would open up straight away, but one little comment here. The 6 millimeter nail is a bit too weak a structure. Looking at my own complications, which I have created, wherever I've covered below 6.7 millimeter nail, I've had a nearly 20% incidence of implant breakage and non-unions. So 6 millimeter nail is something I would always keep a plate ready in this situation as a bailout.
Okay. EMS?
I would prefer plating in these situations because 6 mm is really worrying me. Yeah.
Okay. Sergio?
Can I make a why is 6 minutes? It's quite a bit of space around. I can see that easily. You can go to 7 millimeter ball.
Yeah, this is where I think your nail is fantastic, because I think just looking at it, you are exactly in the axis of the humerus.
That's the thing. That is
the trick.
That's the exactly that. That's what I try to say. But here, what happens? You start from the laterally, then you come to the medially. But the axis is the most important part.
Correct. So, will you explore, Sergio, or you will wait?
You see, this is a difficult scenario. I've been asking myself for a lot of time. I am not running away from the answer, but see, as long as the surgeon knows, pay attention, as long as the surgeon knows that the guide wire was inside of the shaft and that the reamer was inside of the shaft, I would not be worried about mechanical lesion, but rather than that, about the thermical lesion. You understand? The lesion by heat. And in that sense, I would definitely wait, because the problem is when you have a mechanical lesion, which is neurotmesis and not neuropraxia. So the thing is, with neuropraxia, it's just a matter of waiting. But my question, so you see, I would not explore as long as I was sure that the key wire was all of the time inside of the shaft. So no chances of mechanical, of a tear in the nerve. But rather than that, of thermical nerve. But having said that, my question to Dr. Halder is this: if you would open that to explore, don't you think it's logical to have a hand surgeon right with you in the surgical field, ready for neuroraphy? Because see, this is something that I have been asking myself. I am a good shoulder surgeon. I do a lot of shoulder and elbow trauma. But if I open that and I see a tear in the nerve, I am not the guy to do the neuroraphy. Just a second, sir.
Yes.
I want to listen.
Yes, sir. That's absolutely right. When we are doing any kind of nailing, we've got a vascular problem, we call the vascular people stand by. That's as simple as that. Here, I am a hand surgeon as well. I know how to repair the nerve. So if we're going to open up, then I don't have to do that. But if somebody, suppose there's any kind of trauma surgeon has no experience of the nerve repair, he must have a help for that. That is the whole idea. Because here is not the nailing, you are opening the nerve. So you must know who deals the nerve. So you must have at least around him to do the things. But I'm also concerned because here is a 50, England, 50 people say, well, leave it like that, we'll see how in 6 weeks time. What are you gaining living? If you leave and doesn't open up, by this time nerve get contracted and you're going to be a big problem. So first time repair is much better if you want to. And this is nowadays hand surgeon and nerve surgeon and nerve repair people, they do very well as long as they do the fresh one.
Anyway, what I have advised is, if there is a good ultrasonologist, asked him to trace the continuation of the nerve, and if the patient is ready to wait for 6 weeks, wait and get the nerve conduction test done. Otherwise, open up. If the patient is not ready to wait, it's better to open up, because pre-operatively there was no nerve palsy. So yes, Sergio.
And another thing, you see, I have been through these problems many times, or reasonable times. And another thing that I think it's important is to have a good medical-patient relationship in order to take care of the psycho-emotional aspects of the patient. Because see,
absolutely.
Yes, because see, the patient must trust you. A lot of you see a lot of ghosts will haunt his mind, and it's not, I'm sorry, Shiva, it's not 6 weeks, many times 10 to 12.
Yeah.
So see, and this is what I say, it's 3 months when the doctor cannot sleep because of stress. So these are very difficult situations, but in spite of all of the decision of exploring doing electroneuromiography after 4 weeks because of Valerian degeneration, or waiting, the psycho-emotional aspects of the patient must be taken care of, and a good medical relation must, I would say, must be taken care of, especially because, and in India it happens too much, the patient would go for a second opinion, and that second doctor would say bad things about you in spite of not being your fault. And this is the trigger for this can be the trigger for medical legal problems. We know that. So the psycho-emotional of the patient must be taken care of. I think that everybody agrees with me.
Absolutely.
Yes. Yeah. I'll go away from this. It's an infection I'll take. This was a case with the comminuted fracture treated with a plate in this fashion. And for almost 1 year, there was no problem. This was in 2019 May, the patient was operated. So these are subsequent follow-up pictures. But in last May, that is 2 months back, the patient started complaining of pain, and she started getting swelling. And in June, there was an abscess that was drained and fixed in this fashion with a uniplanar external fixator. This was the time she reported to me for the first time. And you can see that the wound was kept open after removal of the plate, and it was packed with all gauze piece and dressing material so that drain could happen. And the patient had pain, lot of pain, because the pins were slightly loose and they were all unicortical, few of them. not folding, because you can see that they were not folding well on the bone. So I just added another rod to supplement this and started doing the dressing on alternate day, and subsequently we started using medicated collagen granules. The wound healed quite quickly. Actually, I was planning for a VAC application in this patient, but the wound healed so quickly, I had no time to think of doing VAC also. But yesterday the lady came with the distal 2 pins walking out. What to be done now? This is yesterday's picture. What can be done? Yes, Sergio.
You see, hopefully, well, are you listening to me? Are you listening to me?
Yeah, yes, yes.
Okay, so see, so hopefully, thanks God, these cases, they are very rare in my practice, but they come, and I discuss this, and luckily, or as a coincidence, the Elizarov guy of my public hospitals, he works with me in the same day. So in my mind, this is the only absolute indication for Elizarov, which is an infected non-union. So when we're talking about humeral shaft, I would do here an Elizarov with an Elizarov guy. And in my opinion, the indication, as far as I know, and I study that, is absolute. I see absolutely no other indication for an infected non-union of the humeral shaft than an Elizarov.
Yes. PMS, you have any other option?
I don't think so, because I do not see such cases.
Okay, fine. Yeah. Rajiv?
Yeah, I mean, you're looking at the middle segment, that's really dead and sclerotic. And he'll need quite a massive debridement and removal of all the dead bone, which will, Elizarov is the only way out. Okay. Elizarov, docket, and then later.
Yes, Subhash, would you like to take, or shall I proceed further?
Proceed further. Let's see what happens.
Okay, fine. So this is what the same case is. This is a case from Dr. Naveen Tucker. So a polytrauma case with proximal humeral fracture. Probably this is for Sergio. What he does is he uses a TENS and he does the anterior bridge plate. You can see that the ABP has been done. From distal part, he has passed from the lateral condyle, he has passed the TENS. This is the picture. Yes. Any comments? Yes, Sergio? Yes.
So
thumbs up.
In the beginning of March, which is basically 3.5 months ago, we did a very interesting webinar, and Shiva was there, and I made a 45 minutes lecture about anterior bridge plating. And the thing is, I have a lot of experience in that, you guys know. And the same thing I told Naveen, because he was the moderator at that time, I'm gonna say again, and Shiva was there, and Shiva is here now. With all respect, this is a misconception, because you cannot have an external device in terms of being in the periosteum and an internal device at the same time. So many people have been asking me that so what people do in India is that they put transient key wires in between the shaft while they apply the anterior bridge plating. With all respect, it's not needed, but I accepted if you do this during intraoperatively and if you take it out. So it's not because this case had a wonderful final clinical and radiographical outcome that this is from a conceptual point of view. This is, I would say, allow me to say the word correct. This is a misconception. So you cannot do it in the femur. You cannot do in, I would say, in the tibia. You do. This is what to conclude that I learned here. That is not half pregnancy. The woman is pregnant or the woman is not pregnant. It's not half pregnancy. So it's one way or the other. And besides this technical misconception,
this is twin pregnancy.
Yeah,
this
but
is
see,
pregnancy.
Yeah, but see, in this case, there was a damage in the periosteum and in the endosteum. This is not good.
Yeah, but
Can I
anyway,
just
I
add-
also used in few cases. This
can I
makes
just-
our life easy, because when I open for the plate from the top, from there only I put only one wire. And in, as you said, in few cases I have removed the wire, but in few cases I have retained it. Our
Okay.
life becomes very, very easy. Yes, yes, Rajiv. Sorry.
Now, the other little worry I have, which I agree with Sergio, is what it does to the mechanobiology, the stress distribution, we do not know. Because this works on a concept, which pretty works the concept of stress being distributed over that segment. You add another implant in, you are concentrating some more of stress in that area. So it might be detrimental in the long run, might be, I do not know. Because you're adding
Actually,
another
it is
implant.
distributing the stress. See, the
No,
plate
two
is ending
implants.
here, so the wire is going there, and the stress is
But
giving.
I'm talking of the fracture side. There the stress is getting concentrated by adding another implant.
Okay, another comminuted fracture.
Shiva, can I make a comment? Shiva.
Yes, yeah.
So,
Yes.
but see, in spite of agreeing with with what Rajiv have said,
Yeah.
Dr. Rajiv
Yes.
have said, there is one thing that I think that it's very important. In spite of being based on established mechanical concepts, okay, of bone healing, you have to trust what you do. So it's beautiful to see that Dr. Halder, he trusts so much, and his results are time proven. And see, so again, I'm sorry to say, because the metaphor is very good, no half pregnancy. So if you trust ABP, as I do a lot, and my results, they are reproducible in my hands and in India, you have to trust it. So doing both things at the same time, it's written in the books. It's not my opinion. It's a misconception, and you do and you damage the endosteum, the periosteum, and it shows that from a practical philosophical point of view, the surgeon is not trusting in the technique. Dr. Rajiv, do you agree with me, Rajiv?
Absolutely.
Okay.
Absolutely.
Yeah, thumbs up. This is a Thirumalaisamy case. Thirumalai, would you take over?
Yeah, this is just a routine anti-grade nailing, and with a commuted situation, it works well, and nothing secret about it. And the next case I'd like to discuss, a very hefty man. I think he was from Germany. He had a work pattern here, or work in India. He got this crushed injury of left humerus, I think. And what would have been the best possible way of fixing it? I would
We'll
request.
start with Sergio. Sergio first, then Rajiv, then Haldar. Yes, Sergio.
See, I am not ashamed of saying what I have to say and what I will say now. The thing is, I don't do nails. I think that this is a very good indication for a nail, but there are some situations in which, at least in my hands, considering that I am very good with plates and anterior bridge plating, and considering that I don't do nails and I don't have the knowledge, okay, I know basically nothing. The thing is, sometimes, and that happened twice in 2019, unfortunately, I have to do an incision from Chandigarh to Kochi, you know, through all India, from Ludhiana to Chennai, a very big one. So I would, and I am not ashamed of that, I would do an extended delta pack, a gigantic one. But listen to me, I would put 2 plates, and the first one is a DCP plate in the shaft, because when you do a philos, it's absolutely impossible to do a philos in this case if you don't have a shaft as a unit to manage the shaft through the elbow. So it's a mistake, in my opinion, to put first the philos with a gigantic approach and then the DCP in the shaft. Rather than that, a DCP in the shaft with 3 screws out, with 3 up and 3 down, interfragmentary screws if possible, and then you have the shaft as a unit, and then you put a philos. Unfortunately, in my hands, that's the only thing I can do. and results, they are good. But see, the morbidity of the approach is gigantic.
Yes, Rajiv, I know so Haldar is going to do nailing from retrograde.
Yeah, sure.
So I'll ask only Rajiv before proceeding further. Yes.
I would go for a long philos. My plan would be basically first go down first, identify the radial nerve, because that's the area where it gets hurt the most. That area expose and take it out of the way. Get a philos, bend it down in the inferior bed so that twist anteriorly. Go to the top, do a and not the delta pectoral but the lateral approach. Identify tuberosity, tie it down, slide the philos down. Yeah, that's what an addition.
But Rajiv, just a second, Rajiv. Yeah. Your incision would be gigantic like mine.
Yeah. It'll join up. At the end of surgery, I'll start up making small incisions. At the end of surgery, it always joins up.
Yeah, okay.
Yes. Thirumalai, how we have put the plate? Because this is not a twisted plate. It doesn't look like a twisted plate from the picture I'm seeing here.
It is not. In fact, I have erased the deltoid and sutured it back with the ethibond.
Because in the proximal part, it looks lateral, and in the distal part, it looks anterior. How?
I think it's not appropriately taken. The X-rays were not taken properly.
Okay.
And, actually, patient, we followed up at 5-6 months. He was having full movements of shoulder and elbow, and pain. There was no pain. But then he migrated to Germany. Then we lost the follow-up.
Okay. Okay, there is one good, beautiful message I want to read. Dr. Vikas Agassia sent me 2 messages. Super explanation by Dr. Haldar. Thank you 100 times, Dr. Haldar. 100 times. Then another message he sent. Today, I gave standing ovation and clapped for 5 minutes in front of the computer after your lecture. So please pass on this message to Dr. Haldar. So this is the
awesome.
Good messages I have received.
Thank you very much. Thank you.
Yes.
We need the nail coming in as soon as possible to India, because it really answers all the concepts. I mean, straight line.
It is very useful. See, very useful, especially for distal tibial fractures and proximal humeral fractures. Because I have been hearing this lecture since almost 15 years.
That case, you put the plate. I showed one case in a similar type of fracture in a shaft as well as this neck femur and a neck humerus.
Okay. Yeah. Now we are 4 minutes away. Concluding comments by Thirumalaisamy, then Rajiv, then Sergio, and last Mr. Haldar. Thirumalai.
Yeah. Extraordinary meeting, and we learned a lot from Mr. Haldar, and good comments from Sergio, focusing on the basics of fixation. And also he insisted on the importance of CT scan and for the benefit of juniors. And I think Mr. Haldar is an expert and a master surgeon, but still a good 3D CT would give us a more insight about the picture, how we are going to fix the initial phases. But later, maybe just an X-ray would be fine. And I thank Shiva for organizing this, and OrthoTV, as well as Rajiv's good comments. It was a wonderful meeting. I really thoroughly enjoyed it. And I'd like to visit Halifax and Mr. Haldar there in the UK.
Yes, thank you. Rajiv?
I mean, he's covered all the points. It was stupendous magician showing his magic. The good thing about him is he stuck to his guns and has proven it time and again. And, it made a lot of sense today to me. Having the name, the right axis, getting it right. So many things were answered. Thank you, sir. Thank you, Sergio, for your incisive comments.
Thank you, Rajiv. Thank you.
It is wonderful.
Sergio,
wonderful.
Sergio. Yeah, Sergio.
I'm gonna make a very short comment, but see, it's a funny thing, but it's very real. In 10 days, it's my birthday. I'm doing 45, so I am thinking about what I have learned in my life in 45 years of existence. And the thing is, I was talking with my wife yesterday. I guess that the big message that I am learning when I am doing 45 is to look at the contradictory. It means the opposite things that I have done, to have a different view, and not to say it's not acceptable, but to try to learn with very different things that I am doing in my life. So in spite of acting quite differently from Dr. Halder, it's a gift to me to see all of these ideas, because they are going to shake my mind. And this is one of the intentions of these events, to think about different ways, and to, you see, whenever we open our eyes, our minds become bigger. And this is the big intention of these webinars. And I guess that we had this. So Dr. Halder, thank you. And you see, Shiva was talking a bit, was telling me 2 days ago about your magical hands, but it's not magical. It's magical and real. And this is the beauty.
Thank you.
Mr. Haldar, any comments before we close now?
No, thank you, Sergio. Thank you very, very much. I don't deserve that much of praise. It's not a magic. As I start with that, is the way I fix the fracture. You might not like it. That's a different way to do the things. That's fine. But that's the way I do it. I not always copy this or follow the textbooks. Sometimes there's lots of questions comes to me, which I explain why I should this, why I should that. That's the Gamaliel chems. That's this reason of that. And that's the way it falls. Not necessarily you have to follow all the forefathers all the times. You always have to think of the lateral side, what's going on. So that's junior, all this younger generation would think of that. They may be better than me. If I can do operation, anybody can do operation. Only you have to respect the soft tissue. You have to respect the soft tissue. That's
you have to say, if I can do, everybody can do. If nobody can do, I should do. That should be the way I should be able to do. Anyway, as Sergio said, his mind like a parachute. Only once it is open and we are ready to accept it, then only we can play safely. So we should be open to all the ideas, and you will be definitely noticed amongst your peers and others if we are swimming against the tide. Not necessarily that you have to go along with the flow. Sometimes you have to swim against the tide, which Haldar, you are doing that, and people are getting noticed. And definitely your talk today will help all of us, definitely. Sergio, you said you are turning 45 in 10 days time. Birthday wishes in advance for me, and say hello to Victoria on behalf of we all from Sholapur and other doctors who we have met and had nice time with her. So finally, I'd like to thank today all the panelists and the speaker, Dr. Haldar, for this wonderful interaction we had. Thank you, Neeraj and Ashok, for this backhand help. I'll just stop the live streaming, and we can, no, there is no stop recording. Yeah, we have to leave the meeting because there is no stop option available. Okay, thank you. Bye-bye.
Stay safe.
Thank you, and happy birthday.
Happy birthday. Happy birthday, Sergio. Thank you,
Happy
sir.
birthday in advance. Thank you.
You are in Kolkata, isn't it, Rajiv?
Yeah, all have to leave because no, this is still recording is going on. You have to leave. There is no other option. I cannot close from here.
Okay.
Yes.
Thank you.
Thank you.
Thank you.
Leave.
Oh,
I will be the last person to leave.
Okay.
Thank you, Subhash. Bye-bye.
Thank you. All right.
You have to leave the meeting. Yeah.
Okay. Okay, Neeraj, and thank you very much for you helping me all this. Tibia, thanks very, very much. Thank you. Thank you very much. So I'm going now. Leave the meeting.